Hey, hello everyone. Good afternoon, everyone. All right, let's begin this one shot. Let's begin the one shot as far as pediatrics is concerned. Let's try to revise the most important topics of pediatrics over the course of next 4 to 5 hours. Let's begin with that journey. All right. And the first thing that we are going to discuss as far as pediatrics is concerned is growth and development. It is what? It is your growth and development. Now, as far as growth and development is concerned, although these two terms are used interchangeably in common parlance, in common language, you have to understand that they carry radically different meaning as far as pediatrics is concerned. So we might say India is a growing country, and we might say India is a developing country. It will mean one and the same thing as far as English language is concerned. But in pediatrics, growth and development have different meanings. Growth, always remember is what? It's a quantitative process. Growth is a quantitative process, right? While development is what? Development is a qualitative process. Development is a qualitative process. When I'll be talking about growth right now, when I'll be talking about growth, I'll be talking about weight, height, head circumference. All this will involve numbers. I'll say that, the weight of the baby when he's born is 3 kgs and it becomes 6 kgs, 9 kgs, so on and so forth. So numbers are getting involved. That's why growth is a quantitative process. While development, we'll talk about development, we'll talk about milestones. We'll talk about initially when a child is born, he's not able to do anything. Then he gains neck control, then he gains trunk control, then he's able to walk. This is nothing but attainment of milestone and acquisition of new skills. And why does this acquisition of new skills occurs? It occurs because our CNS matures. So development is a qualitative process and it basically refers to CNS maturation. It basically refers to CNS maturation and acquisition of new skills. An acquisition of new skills. An acquisition of new skills. So this is the core difference between growth and development. Growth, quantitative; development, qualitative. Now let's learn about normal growth. Let's learn about normal growth, how the normal weight of the baby progresses, how normal length of the baby progresses, and how will the normal head circumference of the baby progress. Now, when a baby is born, always remember the weight of the baby at birth is around 3 kgs. Some textbooks would have given it as 2.8, some would have given it as 2.9 kgs. But in general, we can assume, and as a whole number, we can assume the birth weight of a baby is what? It's 3 kgs. Let's assume this to be X. Let's assume the birth weight to be X. When the baby turns 5 months, the birth weight is going to double. It's going to become 2x. The birth weight is going to become double. That is going to become 2x. So the weight of the baby, if the birth weight was 3 kgs, at 5 months the weight will become what? 2 times 3 kgs. That is, it will become 6 kgs. It will become 6 kgs. At 1 year, the birth weight is going to triple. It will become what? It will become 3x. It will become 3x. The weight of the baby will become 9 kgs. At 2 years, it will become 4x. It will become 4x. That is 12 kgs. At 3 years, it will become 5x. That is, the weight of the baby will now be 15 kgs. At 5 years, it will be 6x. At 5 years, it will be 6x. That is, the weight of the baby will be 6 into the initial birth weight, that was 3. 6 into 3, that is 18 kg. And at 7 years, it will become 7x. And the weight of the baby will become somewhere around 21 kgs. So this is dependent upon the birth weight being 3 kgs. If let's say the birth weight was 2.5 kgs, at 5 months the birth weight would have been twice the birth weight, that is 5 kgs. At 1 year it will be thrice the birth weight, that is 7.5 kgs, so on and so forth. So birth weight doubles in 5 months, triples in 1 year. Okay, now let's see what happens as far as length is concerned. At birth, a newborn has a length of 50 centimeter. At birth, the baby has a length of 50 centimeter. Now, in the first year of life, the baby is going to gain 25 centimeter in length. The baby is going to gain 25 centimeter in length in this year. So that at 1 year, the length of the baby is going to become what? It's going to become 75 centimeter. It's going to become 75 centimeter. In the next year, the baby is going to gain half of what it gained in the first year. So in the first year, baby gained how much? Baby gained 25 centimeter. The next year, so that is from the first year to the second year, the baby is going to gain half. Half of 25 is what? It's 12.5 centimeter. Can we write it as 12 to 13 centimeter? Yes, we can write it as 12 to 13 centimeter. So from 1 year to 2 years, now the baby will gain another 12 to 13 centimeter. So at 2 years, the length of the baby is going to become 75 plus 12, that is 87 centimeter. It is going to become 87 centimeter. It will become 87 centimeter. Now, in the next 2 years, that is from 2 to 3 years and 3 to 4 years, baby will gain half of what it gained in the second year. In the second year, baby gained how much? The baby gained 12 to 13 centimeter. Now the baby is going to gain how much? 6 to 7 centimeter per year. Now the baby is going to gain 6 to 7 centimeter per year. So that at 3 years, the length will be around 93, 94 centimeter. At 3 years, the length will be somewhere around 94 centimeter. And at 4 years, and this is very important, and this has been asked twice as far as INI-CET is concerned. If you look at past 10-year papers, at 4 years, the length will become what? It will become 100 centimeter. It will become 100 centimeter. At 4 years, the length will become 100 centimeter. So birth length was 50 centimeter. At 4 years, the length is now 100 centimeter. So can I say the length doubling time, the birth length doubles by 4 years of age. The birth length will double by what? It will double by 4 years of age. So can you see one thing very clearly right now? Weight as a parameter is something which is going to grow and gain very rapidly. Length is something which takes time to grow, This will become much more clear when we will discuss malnutrition also. Think about this logically also. Let's say there is a 5-year-old child, he's not taking any food. He's not taking any food for, let's say, 1 week, 2 weeks. He'll drastically reduce weight. Same for us also. Whenever there is a fast, whenever there is, like, let's say, Navratras, or let's say there are Rosas, if we take fasting for a period of time, we'll rapidly lose weight. But length is always going to take time. Length is not something which gains very rapidly, which we can see here. It's taking 4 years to double your length. And length is also not something which you will lose also very rapidly. This brings to a very important concept as far as nutrition is concerned, that for acute nutrition, for acute malnutrition, we'll always use something which is weight based, which tells how the weight fluctuates. While as far as chronic malnutrition is concerned, we'll use something which is height or length based, because length is something which is going to take some time in order to increase also, and in order to decrease or not grow also. Right? And this is very rapidly visible here also in the normal growth patterns as well. Now at 4 years, the baby is what? Double of birth length. The baby is double of birth length, which was 50 centimeter. After 4 years, the baby is going to grow at 6 centimeter per year till puberty. It's going to grow at 6 centimeter per year till puberty. Now my question to every one of you who's watching this video right now, who's watching this online right now, who's watching this, just give me a moment, who's watching this online, right now, what will be the length, what will be the age at which the baby becomes 150 centimeter? What will be the age when the baby becomes 150 centimeter? So I told you at 4 years, the baby is 100 centimeter. Now after that, the baby is going to gain height at 6 centimeter per year. When will the height become approximately equal to 150 centimeter? Tell me in the comment section. Great. Everyone is writing it correctly. It will be 12 years. So we are gaining at 6 centimeter per year. We are gaining at 6 centimeter per year. So we have to gain from 100 to 150, you have to gain 50 centimeter additional. So 50 divided by 6, that is around 8 years. We'll take another 8 years to gain it. So 4 plus 8 becomes 12 years. So at 12 years of age, as everyone is writing, at 12 years of age, your height will triple as compared to birth length. It will become 150 centimeter. So can I write this very simple statement? It's very frequently asked facts. Weight doubles by 5 months of age, triples by 1 year of age. Height doubles by 4 years of age. Height doubles by 4 years of age, triples by 12 years of age. Triples by 12 years of age. Another important question which they love to ask, which they'll ask, has been asked once in INI-CET is, at what age is a child half the adult height? At what age is a child half the adult height? So adult height is approximately 170 centimeter. Adult height, I can say, is approximately 170 to 175 centimeter. That is approximately the adult height. So when is the height half of it? When is the height? Basically, they are trying to ask, when is the height 85 centimeter? They are trying to ask, when is the height 85 centimeter, approximately 85 centimeter. What will answer is going to be what? It's going to be what? When is the height going to be 85 centimeter? Look at it carefully. When is the height going to be 85 centimeter, 85, 86 centimeter? Here, the answer is in front of you. The answer is in front of you. The height is going to be around 85 centimeter at 2 years of age. So can I say that the child is half the adult height at 2 years of age? Because that's when the height is approximately 85 centimeter. That's when the height is going to be approximately 85 centimeter. Child is going to be approximately 85 centimeter. Right? Now, it's not exactly 2 years, slightly prior to 2 years, because at 2 years you are 87 centimeter, 85 centimeter will occur slightly prior to 2 years. So better answer will be slightly prior to 2 years, somewhere around 18 to 24 months. If they ask you even further, you can write it as 18 to 24 months. Now we come to the head circumference. Now at birth, the head circumference is around 34 centimeter. The head circumference is around 33 to 34 centimeter. Now, during the first 3 months, the baby is going to gain head circumference at 2 centimeter per month. And this is a recent INI question. This is a very recent INI question in which they simply asked you, during the first 3 months, what is the rate of increase of head circumference? The answer was very simple. It is 2 centimeter per month. So in the first 3 months, baby is going to gain head circumference at 2 centimeter per month. In the next 3 months, that is from the 4th to 6th month, baby is going to gain head circumference at 1 centimeter per month. And from 7 to 12 months, the remaining 6 months in the first year of life, the baby is going to gain head circumference at 0.5 centimeter per month. At 0.5 centimeter per month. If I talk about the absolute increase, in the first 3 months, the absolute increase is 2 into 3, 2 centimeter per month for 3 months. It's going to be 6 centimeter. In the next 3 months, the absolute increase is 1 into 3, that is another 3 centimeter. Another 3 centimeter. And in the last 6 months, the absolute increase is what? It is 0.5 into 6, another 3 centimeter. So in the first year, the absolute head circumference increase is what? It is 12 centimeter. So this birth head circumference I talked about, which was 34 centimeter, by the time the child reaches 1 year of age, it will be equal to what? It will be equal to 46 centimeter. Add of 12. 34 plus 12 is 46 centimeter. You will gain 12 centimeter in this 1 year. At 2 years of age, it will become what? It will become 48 centimeter. You'll again gain another 2 centimeter in that 1 year time span. What is the adult head circumference? Tell me, what is the adult head circumference? I'm going to ask you a simple question. What is the adult head circumference? What's mine and yours head circumference? What is the adult head circumference? Tell me, what is the adult head circumference? Nikita is writing it absolutely correctly. It's around 53-54 centimeter. It is around 53-54 centimeter, right? So can I say this 48 centimeter? Adult head circumference is what? It is around 53 centimeter. 48 centimeter of 53 centimeter is 90%. So can I say that 90% of adult head circumference you have already gained it by what? By 2 years of age. We have already gained 90% of adult head circumference by 2 years of age. The corollary is that 90% of head circumference is what? It is nothing but your brain. So 90% of your brain growth has already occurred by 2 years of age. That's why in the first year, in the initial years of life, it's very important to take care of the child, because 90% of the brain growth, 90% of the IQ, you'll always already gain by the 2 years of age. That's why we also say that you have to give the mother's milk, the breast milk, rather than formula feeding. Because in the first 6 months when you're giving that, that's what's going to contribute to the maximum amount of growth, the brain growth of the baby. By 2 years of age, 90% of your brain growth has already occurred. By 2 years, 90% of your brain growth has already occurred. Again, this is a very frequent, another question which INI-CET specifically loves to ask. Now, with this, let's come to growth curves, which was asked last year in your NEET PGA. Very important growth curves. Okay. Let's come to first this growth curve. This growth curve, you are going to tell me which growth curve this is. You are going to tell me which this growth curve is. This is. That 90%, we already discussed, 90% of the growth has already occurred by 2 years of age, then it's a plateau. This is going to be growth curve of which tissue? This is going to be the growth curve of which tissue? Tell me. Brain, exactly. So this is how head circumference is progressing, right? And head circumference is nothing but your brain. So this is the growth curve of brain. Then we come here. Let's look at this growth curve of this tissue. Initially, there is a very rapid growth. Then there is a plateau. Initially, there is a very rapid growth. Then there is a plateau. This plateau continues till 10 to 12 years of age, and then at 10 to 12 years, when there is another puberty, there is another uptick. This is going to be denoted by what? This is going to be what? This is going to be which tissue? This is going to be which tissue? This is going to be which tissue? Yes, some of you are writing skeletal tissue, some of you are writing height, some of you are writing somatic. All of you are right. All of you are right. This is how the height is progressing, right? We just talked about that. Initially, height was growing very rapidly, 12 centimeter. Then there was a plateau at 6 centimeter per year. And then at puberty, you will have another growth spurt. So this is nothing but your height. But height is not a tissue. Height is which tissue? Height is denoted by what? It's your skeletal tissue. Skeletal tissue is what? It's nothing but your somatic tissue. So this is height or the skeletal tissue or the somatic tissue Both the things are correct. Then we come to this tissue. This tissue was silent in 10 and 12 years and then suddenly started to grow. Till 10, 12 years, this tissue was silent and then suddenly started to grow. This is nothing but your gonads. Your testes and ovaries. They were silent in 10, 12 years. And when at 10, 12 years, when you will actually have your puberty, they will suddenly start to grow. So this is nothing but your gonads. Okay. There's another question that they love to ask, that gonadal growth is correlated with which growth? Answer will be skeletal growth. See, gonadal growth also occurs at 10, 12 years. That's when the gonads start to grow. And that's also when the skeletal tissue will have their growth spurt. So gonadal growth is correlated with skeletal growth. This is a true statement. Remember that whenever the gonadal growth is occurring, you will also have your pubertal growth spurt and growth in your skeletal or somatic tissue. So these things you have to remember. Next, last growth curve, this growth curve. This is which growth curve? Maximum growth is seen between 4 to 8 years. This is going to be which tissue? This is, yes, exactly. This is going to be your lymphoidal tissue. Your tonsils, basically. And this is correlated in pathology that the commonest age group as far as acute lymphoblastic leukemia, ALL, is concerned, is also this 4 to 8 years age group. Then we come to puberty and adolescence. Then we come to puberty and adolescence. Now, as far as puberty and adolescence is concerned, just like growth and development, these are two terms which are used interchangeably but have different meaning. A for adolescence, A for age group. It's a WHO defined age group. Adolescence is a WHO defined age group from 10 to 19 years. Then what is puberty? P for puberty, P for the physiological changes that occur during adolescence. What are these physiological changes? It is a development of your secondary sexual characteristics. The females starting to have their breast growth, their, menarche, the beginning of their menstrual cycle, the secondary sexual characteristics. That is your puberty. Males having their beard growth, males having their testicular enlargement. That is your puberty. So puberty is what? Puberty are the physiological changes. Puberty refers to the physiological changes. That is the secondary sexual characteristic development in both males and females. Now let's see what will be the sequence of puberty as far as males and females are concerned. As far as females are concerned, the sequence of puberty and in males, both of them can be remembered by the simple term TPM. TPM. In males also, the sequence of puberty is going to be the same. It's going to be TPM. Now, what is the sequence of puberty in females? It is thelarche. The first sign of puberty in females is thelarche. It is the development of the breast tissue. There will be increase in breast size. This thelarche is followed by pubarche. That is the appearance of the pubic hair. And the pubarche will be followed by menarche. That is the beginning of their menstrual cycle. Just prior to menarche, females will have their growth spurt. And remember, the growth spurt in females occurs in Tanner stage 3. So this is the sequence of puberty as far as females are concerned. TPM, thelarche, pubarche, menarche. And just prior to menarche, around 6 months prior to menarche, females will have their growth spurt. As far as male is concerned, males also will have the same sequence, TPM, but obviously males will not have thelarch. The T in male stands for testicular enlargement. It stands for what? It stands for testicular enlargement. It stands for testicular enlargement. That is the first sign of puberty in males. This testicular enlargement will be followed by pubarch and penile growth. Will be followed by pubarch and penile growth, which then would be followed by what I like to call, is not given in textbooks, but for remembering purpose, it's easy that the sequence of puberty in males and females is both TPM. M stands for the manly changes. It stands for the manly changes. So what are the manly changes that differentiate you from a woman? So beard, voice change. All right. So this is what the beard growth and the voice change. It's the beard growth and the voice change. And just like females were having their growth spurt prior to menarche, males will also have their growth spurt just prior to the manly changes. They will also have their growth spurt. But remember, growth spurt in males occurs in Tanner stage 4. It occurs in Tanner stage 4. Okay. And this is something which you remember from your own pubertal days also. Remember, girls used to have what their growth spurt earlier as compared to boys. In the 5th, 6th, 7th standard, it was the girls who used to grow taller than boys. Boys used to stay shorter. Later, during the 7th, 8th, 9th standard, that's when the boys will have their growth spurt later in Tanner stage 4. That's when the boys used to start to grow. So this is something which you remember from your own puberty. You should not forget, girls will have their growth spurt earlier in Tanner stage 3. Males will have their growth spurt later in Tanner stage 4. Now, very important question, one important question that they ask is, what is the first biochemical evidence of puberty and which is the best marker of pubertal status? Now, the best biochemical evidence of puberty, the first biochemical evidence of puberty, that when does the body get to know, or the testes and the ovaries get to know, okay, start secreting testosterone and estrogen, now the puberty has to start. It is your GnRH pulse. It is the pulsatile GnRH secretion. It is the pulsatile GnRH secretion. Before puberty, before 10 or 12 years of age, when puberty hasn't occurred, GnRH is always secreted in a constant manner. When puberty starts, GnRH starts to get secreted in a pulsatile manner. Pulsatile manner means when there will be ebb and a flow, up and down, up and down. And this pulsatile secretion usually occurs at around night. That's why they say that during puberty, during the adolescent age group, it's very important that you have a proper good night's sleep, because that will allow the GnRH secretion to take place and puberty to progress. But when they ask you what is the best marker of pubertal status, it is not GnRH. You have to understand, when you are asking what marker means you are testing for it. You want something which has a cutoff. That above that cutoff you can say puberty has started, that this hormone is high means puberty has started, or this hormone is low means puberty hasn't started. This is particularly important as far as precocious puberty or delayed puberty is concerned. Let's say a female comes with delayed puberty, 16 years. You want to assure it with the help of some marker, with the help of some lab marker. Then you need some marker which is below a cutoff. Or let's say someone has come with precocious puberty. You need a marker which is above a cutoff that can say, okay, puberty actually has started at an earlier age point, time point, and this particular child, precocious puberty. Now this marker cannot be GnRH, because GnRH, like I told you, pulsatile secretion. To know whether puberty has started or not, you would have to see the pulsatile secretion. So you would have to take multiple samples. You would have to take samples at 10 o'clock, then 10:30, then 11 o'clock. Or you have to put a cannula and do a continuous sampling. Not feasible. So as far as the best marker is concerned, it's actually your pituitary hormone, your LH. LH is considered a better marker as compared to FSH. The best marker of pubertal status is actually your LH. It's your pituitary hormones. Among pituitary hormones, LH is the best marker. So first, biochemical evidence, pulsatile GnRH secretion, best marker, LH. Best marker, LH. Then we come to the Tanner staging. Then we come to the Tanner or the SMR staging. First, let's discuss what happens in males, and then we'll discuss what happens in females. Now, some basic concepts. Tanner stage 1 will always be prepubertal. Tanner stage 1 will always be prepubertal. And Tanner stage 5 will always be the adult pattern. Now, coming to Tanner, from Tanner stage 1, let's come to Tanner stage 2. So, what is the Tanner stage 2? That's when puberty will start. What was the first sign of puberty in males? It was increase in testicular size, testicular enlargement. So in Tanner stage 2, you will have an increase in testicular volume, you will have an increase in testicular volume, which will become equal to 4 ml, which will become equal to what? It will become equal to 4 ml. Along with that, from after T comes P, TP, right? So there will be pubic, so there will be small amount of pubic hair. There will be what? There will be sparse pubic hair. There will be sparse pubic hair. Now, this testis is housed by what? It's housed by scrotum. It's housed by scrotum. Now, this testis, when it suddenly increases in size, till 10 years, this testis was 2 ml, 3 ml, basically less than 4 ml. And now it is suddenly going to increase in size. The scrotum skin also has to suddenly expand. Now, when the scrotum skin suddenly expands, whenever there is sudden expansion of skin, the skin undergoes a little bit of reddening. So you'll have what? You will have scrotal reddening because of this sudden increase in testicular volume. You will have a scrotal reddening. You'll have scrotal reddening. So this is Tanner stage 2. Then we come to Tanner stage 3, pubar penile growth, right? Penile growth. So you'll have increase in penile length here. You'll have increase in penile length here. And Tanner stage 3, the third letter of English alphabet is C. This sparse pubic hair will now start to grow and they will start to become coarser in texture, and when they grow, they'll start to curl. So till now it was a very small pubic hair. When it starts to grow, it will start to curl. So pubic hair will undergo coarsening and curling. They'll undergo coarsening and curling, and there will be increase in penile length. Alright, so you can remember Tanner stage 3, third letter of English alphabet, C, coarsening and curling of pubic hair. Then coming to Tanner stage 4. So I already told you in Tanner stage 4, there will be the growth spurt in males. So growth spurt, they'll start to grow at around 10 to 11 centimeter per year. They initially were growing at 6 centimeter. In growth spurt, they will start to grow at 10 to 11 centimeter per year. Plus, there will be increase in penile girth. There will be increase in penile girth. Along with that, if you look at here, if you look at this images, the scrotum and the scrotal skin was what? Whitish, skinish color, whitish. Now it will become dark. There will be scrotal darkening. We all know our secondary sexual organs, they're darker as compared to the rest of the body. And this darkening occurs in Tanner stage 4. There's going to be scrotal darkening. And finally, Tanner stage 5, you will have adult pattern, and the testicular volume will become equal to, it will become so huge, it will become equal to 25 ml. How can you remember the testicular volume? You can remember testicular volume by square of that Tanner stage. So in Tanner stage 2, 2 square, testicular volume is 4 ml. Tanner stage 3, 3 square, testicular volume is 9 to 10 ml. Tanner stage 4, 4 square, 16 ml. And finally in Tanner stage 5, 5 square, it's going to be equal to 25 ml. So this is as far as Tanner staging in males is concerned. Then we come to Tanner staging in females. So same concept. Stage 1 is going to be prepubertal. Stage 1 is going to be what? It's going to be prepubertal. Stage 1 is going to be prepubertal, while stage 5 will be the adult pattern. Coming to Tanner stage 2, that's when puberty will start. So what is the first sign of puberty? TPM, T, thelarch. So we'll have breast growth. There will be appearance of the breast bud. TP, pubar, sparse pubic hair. So sparse pubic hair. Tanner stage 3. So females, they have their growth spurt earlier, so they'll have their growth spurt. Remember, growth spurt in females is around 8 to 9 centimeter per year. Right? Girls are shorter than boys, so their growth spurt is also going to be slightly lower as compared to boys. Boys was 10 to 11, girls will be 8 to 9. And again, the pubic hair now, third letter of English alphabet, Tanner stage 3, both males and female, third letter C. It will undergo coarsening and curling. There will be coarsening and curling of pubic hair. Then we come to Tanner stage 4. As far as Tanner stage 4 is concerned, most important thing is, till now the breast was growing in a smooth manner. Now what will happen in Tanner stage 4? The nipple and the areola, it will slightly protrude out of the rest of the breast tissue. If you look at the breast is like this, and the nipple and the areola, they are actually slightly protruding out. Okay, they're forming a mound, they're forming a small kind of a concavity on top of the rest of the breast tissue. Okay, so now the breast is going to grow like this, but the nipple and the areola, it will form a secondary mound over the rest of the breast tissue. This is called formation of secondary mound by the nipple and areola. The pubic hair will be the inverted triangle pattern. It will look just like adult. It will look just like adult, except the pubic hair will not be present on the medial aspect of thigh, except medial aspect of thigh or medial thigh. But as far as adult is concerned, in adults, in us also, we know that some amount of pubic hair is present on medial aspect of thigh as well. So Tanner stage 5 will be the adult pattern where you will have presence of pubic hair on medial thigh as well, medial aspect of thigh as well. So this is as far as puberty is concerned, adolescence is concerned, Tanner staging is concerned. Now we come to assessment of growth. So we discussed growth, how growth occurs. Now let's see how we can assess growth. Now growth can be assessed with the help of age dependent parameter and age independent parameter. It can be assessed with the help of age dependent parameter and age independent parameter. Now as far as age dependent parameters are concerned, let's understand what do you mean by age dependent and age independent. Age dependent means that you need to know the age of the child. It's telling you age dependent means you need to know the age of the child. Age independent means you don't need to know the age of the child. They will have cutoff. If it is above a cutoff, it is normal. If it is below a cutoff, you will say the child is not growing properly. That is, not growing properly means child is malnourished. So age dependent cutoffs require to know the exact age of the child. Age independent, you don't need to know the age of the child. Simple. So age dependent parameters include your weight for age. It includes your height for age. And it includes your BMI for age. While age independent parameters include your weight for length, MUAC, which is basically your mid upper arm circumference, and skin fold thickness. There are certain other age independent parameters. You don't need to know the depth of them, just remember the name, called Gillespie ratio and Kanavati index. Kanavati and Maclaurin, they sometimes call it Kanavati and Maclaurin index. So Gillespie ratio, Kanavati and Maclaurin index. So just the names are important. They are also age independent. Now, let's talk about the assessment of growth using these parameters. First, we'll talk about height. Now, as far as height is concerned, so till now I've used the term height and length interchangeably, but they mean different things. Even normally we also say that's the length of the patient, that's the height of the patient. We can use it interchangeably, but again, they have different meaning. Length refers to this. Length refers to the lying length. When you're lying supine, that's what you measure is what's called as length. Length basically refers to the lying supine length. When you're lying supine length. Height refers to standing height. When you're standing, that's what you measure is called height. Height basically refers to standing height. So obviously height can only be measured when a child learns how to stand. That's why height is usually measured in children more than 2 years, while length is measured in children less than 2 years. A child less than 1 year is called what? A child less than 1 year is called an infant. That's why this instrument which we are using to measure the length of the baby is called less than 1 year infant. This instrument is called infantometer. Well, standing, height is measured standing. That's why this is the instrument. This is what? This is a stadiometer. This is what? This is nothing but a stadiometer, standing height. Height measured for more than 2 years, length measured for less than 2 years, length less than 1 year is an infant, so instrument name is infantometer. Standing height, stadiometer. Then we come to mid upper arm circumference. So mid upper arm circumference is measured with the help of this tape called Shakir's tape. This tape is called Shakir's tape. Now, where do you measure the mid upper arm circumference? Here. You need to have a specific point. So measure it exactly at the midpoint between here, the olecranon process, and here, the acromion process. Olecranon process of the ulna and acromion process of the scapula. Alright. So exactly the midpoint. Where do we measure this mid upper arm circumference? If this is the acromion process and this is the olecranon process, Then we'll measure this mid upper arm circumference exactly in the middle. We'll measure it exactly in the middle. Now this mid upper arm circumference, like I told you, will have cutoffs. It's an age independent parameter. If it's above a particular cutoff, we'll say the child is normal. If it is below a particular cutoff, we'll say child is abnormal or child is malnourished. So this cutoff is what? It's 12.5 centimeter. If the child is more than 12.5 centimeter, if the mid upper arm circumference of the child is more than 12.5 centimeter, then in the Shakir's tape, it is coded as green and child is considered to be normal. Child is considered to be normal. If the mid upper arm circumference that you measured is between 11.5 to 12.5 centimeter, it is between 11.5 to 12.5 centimeter, then that is borderline. And it is coded as yellow in the Shakir's tape. And if the mid upper arm circumference is less than 11.5 centimeter, then that's coded as red, and that denotes what? Malnourishment. It denotes severe acute malnourishment. Or SAM. It denotes SAM. So this is how the Shakir's tape is going to look like. If the mid upper arm circumference will be more than 12.5, it will be coded as green. If it's going to be between 11.5 and 12.5, it's going to be coded as yellow or basically borderline. And if it is less than 11.5, that will be SAM or child is malnourished. So this is your mid upper arm circumference. Then we come to skin fold thickness. This, you can measure the skin fold thickness here. Thickness of the skin fold here or here, a bit behind the back. This is the skin fold thickness. This is also age independent parameter. This is measured with the help of this instrument called Harpendon's caliper. Now, most common site is what? The most common site is this only, triceps. This is the most common site to measure your skin fold thickness. Other sites include your biceps. They include your scapula. Behind back, basically. Now, when this skin fold thickness is less than 6, it's less than 6 mm, then the child is said to be malnourished. Child is said to be malnourished. And when the skin fold thickness is more than 10 mm, then the child is considered to be normal. Okay. So this is as far as skin fold thickness is concerned. Now we come to a very important part, that is vitamins. A little bit of this would have been discussed in biochemistry as well. Vitamins, very, very important. 1 or 2 questions related to vitamin is a given in your exam. All right. So let's discuss about vitamins and minerals. First, the distinction between vitamins and minerals. There is fat-soluble vitamins and there is water-soluble vitamins. The fat-soluble vitamins includes your vitamin A, D, E, and K. The fat-soluble vitamin includes your vitamin A, D, E, and K. The water-soluble vitamins includes your vitamin B complex and C. What is important about fat-soluble vitamins is they can be stored in the body. They can be what? They can be stored in the body. And where are they stored? All of them are stored in the liver. So vitamin A is stored in liver, D is stored in liver, K is stored in liver, all of them stored in liver. Water-soluble vitamins, because of their water solubility, will be excreted in the urine and cannot be stored in the body. They cannot be stored in the body. There is one exception to this rule, that is your vitamin B12. B12 is the only water-soluble vitamin which can be stored in the body. Rest cannot be stored in the body. And because they cannot be stored in the body and they are easily excreted out through the urine, there will never be symptoms of excess of these vitamins. They will never demonstrate any symptoms of excess. While all the fat-soluble vitamins can also demonstrate symptoms of excess or toxicity. They can also demonstrate symptoms of excess or toxicity. So this is a core difference between water-soluble and fat-soluble vitamins. Water-soluble vitamin, because they can be excreted in urine, cannot be stored, always excreted out, don't have symptoms of excess. Fat-soluble vitamins can have symptoms of excess, stored because they are stored in the body. Now first, let's begin with the discussion of water-soluble vitamins, that is your vitamin B and C. First is thiamine. Now, what is the main function of thiamine in the body? It's a part of TCA cycle, the citric acid cycle, basically. It's a part of involved in TCA cycle. Now, TCA cycle helps in what? It helps in ATP generation. So, the enzymes involved in vitamin B1, enzymes which require vitamin B1 are ATP enzymes. These are your alpha ketoglutarate dehydrogenase, trans ketolase, and pyruvate dehydrogenase. These are the three most important enzymes which require vitamin B1 for its function. If they ask you amongst this enzyme, which is required, which enzyme is used to determine vitamin B1 status in the body, the answer is going to be transketolase. The answer is going to be transketolase. This enzyme is used to determine vitamin B1 status in the body. It's used to determine vitamin B1 status in the body. Now, deficiency of vitamin B1, we all know, leads to what? It leads to beriberi. Beriberi can be of two types, wet and dry. It can be of two types, wet and dry. Now, whenever the vitamin B1 is deficient, vitamin B1 energy generation, ATP production, if it is not there, ATP production is going to get compromised. And which organs in our body require the maximum amount of ATP, maximum amount of energy? It's your dil and dimag, heart and brain, dil and dimag, right? They require the maximum amount of energy. So these are the organs which are going to get affected as far as beriberi is concerned, depending upon which type it is, whether it is wet or dry. In wet beriberi, it is the heart which is affected. You end up having high output cardiac failure. You end up having what? High output cardiac failure. Because there is cardiac failure, there will be a lot of edema. Because there is edema, that's why it's called wet beriberi. In dry beriberi, the symptoms will predominantly be of neuropathy. The symptoms will predominantly be of what? They will be of neuropathy. Why does beriberi occur? And this was asked last year in EPG. It occurs if you take a diet which is extremely rich in polished rice. Which is rich in polished rice. Basically a lot of basmati rice. So they had given you a picture of polished rice and asked what will occur if you take a diet which is rich in this. The answer was beriberi. If you take a diet which is extremely rich in polished rice, basically the husk of rice contains a lot of B1. So if you polish it, you're removing that husk, you're removing that vitamin B1, and you'll end up having vitamin B1 deficiency. So diet rich in polished rice results in vitamin B1 deficiency, that is beriberi. Then we come to vitamin B2. Vitamin B2 is riboflavin. It's a part of succinate dehydrogenase. And glutathione reductase. Succinate dehydrogenase and glutathione reductase. And succinate dehydrogenase results in formation of FAD and FADH2. That also has riboflavin or B2 as its component. So it's a part of succinate dehydrogenase and FADH2. If they ask you which enzyme is used to determine vitamin B2 status in the body, the answer is going to be glutathione reductase. Glutathione reductase is used to determine B2 status in the body. What will B2 status lead to? B2 status deficiency, B2 riboflavin deficiency, we all need to glossitis. Around the mouth, there's going to be a lot of inflammation. Angular cheilitis, glossitis, cheilitis, mouth ulcers. So there's going to be angular cheilitis. There's going to be angular cheilitis. The second thing that it leads to is here. It will lead to formation of new vessels. It will lead to formation of these new vessels inside the cornea, which is called as corneal neovascularization. So that's the second thing that it will lead to. It will lead to corneal neovascularization. It will lead to corneal neovascularization. All right. Then coming to B3. B3 is your niacin. Niacin makes up what? Niacin makes your NAD and NADPH. That's the main function of niacin in our body. Niacin deficiency, we all know, leads to what? It leads to pellagra. Niacin deficiency leads to pellagra. Pellagra with its 3 Ds. What are the 3 Ds of pellagra? Diarrhea, dementia, and dermatitis. You all know that? Diarrhea, dementia, and dermatitis. These are the 3 Ds of pellagra. As far as dermatitis is concerned, let's look at the dermatitis. Let's look at this picture. If you look at this picture, you can see that the dermatitis is here. This is where you can make out. This is where the dermatitis is. This is hands. This is where the dermatitis is. Neck. This is where the dermatitis is. But if you look at the chest, can you see? You can probably make out that the person was probably wearing a banyan. And the chest is actually spared. The chest doesn't have dermatitis. The chest doesn't have dermatitis. So what does this tell you? This tells you that dermatitis is affecting here, 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 but not affecting the chest, which was covered by the banyan. So it basically, the dermatitis affects only the sun exposed areas. The dermatitis basically affects only the sun exposed areas. It only affects the sun exposed areas. It only affects the sun exposed area. And the dermatitis here we all know is known as Castle's necklace. The dermatitis here on the neck is called Castle's necklace. It's called Castle's necklace. The dermatitis here is called Castle's necklace. Now, in a body, even if you're not taking adequate amount of niacin, there is another trick up the sleeve of the body. Body can actually make niacin from tryptophan. It can actually make niacin from tryptophan. 60 mg of tryptophan can get converted into 1 mg of niacin. The pathway is called kynurenine pathway. The pathway is called kynurenine pathway, and this pathway requires the function of vitamin B6. It requires vitamin B6 as a cofactor. Now, what this actually also means is that whenever, let's imagine a situation that tryptophan is not there in the body, then also there will be no niacin in the body. So tryptophan deficiency can also result in niacin deficiency. That is, if there is niacin deficiency, there will be what? There will be pellagra. That's why pellagra is also seen. Pellagra is also seen in tryptophan deficiency. It's also seen in tryptophan deficiency. And when does tryptophan deficiency occurs? It occurs in 4 scenarios. First is the most important, that is a maize-rich diet. It is a maize-rich diet. Why maize-rich diet? Because maize does not contain tryptophan and it has high amounts of leucine. It doesn't contain tryptophan, it has high amounts of leucine. Leucine is known to inhibit this kynurenine pathway. It's known to inhibit this kynurenine pathway that I talked about. Second, it can occur in a disease called as Hartnup disease. It can occur in a disease called as Hartnup disease. Occur in a disease called as Hartnup disease. So this Hartnup disease is an autosomal recessive disorder where there is a defect in neutral amino acid transporter. There is a defect of neutral amino acid transporter. So you won't be able to absorb tryptophan. If there is no tryptophan absorption, what's going to happen? Tryptophan, no tryptophan in the body, tryptophan deficiency, no tryptophan, no niacin, pellagra. The third thing that can result in tryptophan deficiency leading to pellagra or pellagra-like symptoms is serotonin syndrome. Serotonin syndrome. In serotonin syndrome, what happens is that this tryptophan, this can make 2 things. It can make your niacin, it can make your serotonin. It can make niacin, it can make serotonin. In serotonin syndrome, what is the body synthesizing? It's synthesizing a lot of serotonin. So all the tryptophan is diverted towards serotonin. As a result, no niacin is formed. So this happens in serotonin syndrome. That's why serotonin syndrome can also result in pellagra-like symptoms. And certain drugs like isoniazid, we all know isoniazid is known to inhibit vitamin B6. If there is no vitamin B6, the tryptophan to niacin conversion won't occur. So this is as far as niacin is concerned. Very important. Multiple questions related to pellagra and what can lead to pellagra have been asked. Then we come to vitamin B5. Vitamin B5 is pantothenic acid. It's a part of coenzyme A. It's a part of coenzyme A. Its deficiency results in burning foot syndrome. Its deficiency results in burning foot syndrome, particularly a very severe form of dermatitis referred to as burning foot syndrome. Then we come to pyridoxine. Now, the important function of pyridoxine in our body is carboxylation. It's decarboxylation. It's decarboxylation. It is decarboxylation. Decarboxylation reactions in the body. Decarboxylation reactions in the body are what? You might have learned this in biochemistry. Dopamine formation. Okay, serotonin formation is decarboxylation. Similarly, it is involved in heme synthesis. And it's also a cofactor for ALT and AST. It's also a cofactor for glycogen phosphorylase. It's also a cofactor for glycogen phosphorylase. Now, we all know vitamin B6 is inhibited by which drug? Which drug causes vitamin B6 deficiency? It is your isoniazid. And whenever there is whenever there is isoniazid, we give isoniazid to a patient with TB as a ATT therapy, we always prescribe vitamin B6 with it. If vitamin B6 is not given, it can result in neuropathy. It can result in peripheral neuropathy. It can result in peripheral neuropathy. As far as newborns are concerned, neonatal period is concerned, it can result in what? This neuropathy can be even more severe. This nerve damage and loss of this serotonin, dopa, all these neurotransmitters are not there. So obviously it can lead to seizures as well. It can lead to neonatal seizures. Because heme is not there, deficiency of vitamin B6, no heme synthesis. If there is no heme, there is no place for iron to go. This iron gets deposited inside the RBCs. This excess iron inside RBC is called what? Sideroblastic anemia. So its deficiency can also lead to sidro. This heme synthesis deficiency can lead to sideroblastic anemia. And since it's a cofactor for ALT and AST, if vitamin B6 is not there, ALT, AST will have to work double. They have to do extra work. So ALT, AST levels will increase. There will be increased ALT, AST level. That there will be transaminitis as far as deficiency of vitamin B6 is concerned. That's why isoniazid also results in increased ALT, AST levels. Then we come to biotin. Biotin is also known as vitamin H. It is also vitamin H. Its main function is opposite of pyridoxine. Pyridoxine was decarboxylation reaction. Biotin is involved in carboxylation reactions. It's involved in carboxylation reaction. Its deficiency characteristically manifests when you are taking a lot of raw white eggs. You're taking a lot of raw white eggs. Why? Because these raw white eggs contain something called as avidin. And this avidin binds to biotin, does not allow biotin absorption. And eating this raw white egg leads to biotin deficiency, and biotin deficiency characteristically manifests as alopecia. In fact, this is very common. Even if you go to a dermatologist, any one of you suffering from hair loss, I'm so sorry. Any one of you who's suffering from hair loss, if you go to a dermatologist, ask them, the first thing they will give you is biotin tablets. Biotin deficiency characteristically leads to alopecia. Which leads to what? It leads to alopecia. Leads to what? Leads to alopecia. Then we have vitamin B12 and folate. Vitamin B12 and folate. Both of them are what? They are involved in DNA synthesis. Both of them are involved in DNA synthesis. Remember, vitamin B12 is present only in animal sources. It's present only in animal sources. That's why vegans particularly will be at a higher risk of having vitamin B12 deficiency. Deficiency of both folate and vitamin B12 results in the megaloblastic anemia. You must have done this in pathology. This results in megaloblastic anemia. As far as B12 deficiency is concerned, there is megaloblastic anemia. Along with that, there will be CNS changes as well. There will be CNS changes. Along with that, there will be methyl malonic aciduria, increase in MMA levels. So this is how you can differentiate B12 deficiency from folate deficiency. Folate deficiency will only cause, in folate deficiency, there will only be anemia. There will only be megaloblastic anemia. But in case of B12 deficiency, there will be anemia, there will be CNS changes, there will be methyl malonic aciduria. These three things will occur in B12 deficiency. Folate will cause only anemia. You should also remember this fact that if a B12 patient, you give them folate, the anemia will resolve, but the CNS changes will actually worsen. If you give folate to a patient who has B12 deficiency, the anemia will get fine because that's what is causing, folate causes only anemia. The anemia will become fine, but the CNS changes and MMA actually might worsen. It might worsen. Then we come to vitamin C, which is basically your ascorbic acid. Basically your ascorbic acid. What's the main function of vitamin C in our body? The main function of vitamin C in our body is hydroxylation of lysine and proline in collagen. It's the hydroxylation of lysine and proline in collagen. That's the main function of vitamin C in our body. Okay. Other function include, it's an antioxidant. It also helps in absorption of iron. It also helps in absorption of iron. These are two other functions. Now, what will happen if there is vitamin C deficiency? We all know it leads to what? It leads to scurvy. And all the manifestation of scurvy can be simply by understood this function. the collagen synthesis function, the hydroxylation of lysine and proline in collagen. Basically, if there is vitamin C deficiency, imagine there is a collagen deficiency in the body. And wherever collagen is there in the body, that place collagen is not going to work. There is not going to be good quality collagen. Collagen is there in gums, no collagen, bleeding gums. It will lead to bleeding gums. Skin. What's going to happen? Skin, collagen is not there. There will be micro bleeds here in the skin, which is called petechiae. So there will be a lot of petechiae. There will be a lot of petechiae. Apart from that, joints, collagen is not there. There will be joint bleeds leading to what? Painful joints. Leading to what? Leading to very painful joints. Sometimes the child is not able to stand because of this, painful joints, called pseudo paralysis. Because he's not able to stand, pseudo paralysis. But why pseudo paralysis? Because it's not occurring because of a CNS effect. It's occurring because of the pain in the joints. So this painful joints can even lead to pseudo paralysis. Then the X-ray changes in scurvy are very important. This is how an X-ray with scurvy is going to look like. So I told you there is going to be bleeding. Collagen is not there. So there's going to be a subperiosteal bleed or subperiosteal hemorrhage. Now this subperiosteal hemorrhage, what will happen? Let's say this is one bone, this is another bone. All the bleeding will accumulate in the middle part, here in the middle part. Now here when the bleeding accumulates, you must have done this in pathology. Whenever there is a bleed, over time, calcification is going to occur. That's why the end of the bones in scurvy will have this excessive calcification. Which is referred to as a dense zone of provisional calcification or white line of Frankel. This is nothing but excessive bleeding which is occurring in between the joint spaces getting calcified. White line of Frankel or dense zone of provisional calcification. Just above that, just slightly above that, there will be a zone where there will be no calcification. This is called the scorbutic zone or the Trummerfield zone. Scorbutic zone and Trummerfield zone. The epiphysis will become ring-shaped. Called ring epiphysis or the Wimberger's ring sign. And because there is problem with collagen, the growth obviously is going to get affected. So the bones won't grow straight. They'll go haywire. And this sideways growth is what is called as Pelkin's spur. So these are the X-ray, very important. These are the 5 X-ray changes you will see as far as scurvy is concerned. Now we come to fat-soluble vitamins. The first one is your vitamin A. Now remember vitamin A, the main function of vitamin A in body. The main function of vitamin A in our body is what? The main function of vitamin A is epithelial integrity and differentiation. It is epithelial integrity and differentiation. The second function is obviously we all know is vision. So what will happen if there is vitamin A deficiency? Your skin, the epithelial integrity is not there. Skin is going to lose all the water. Skin will become very dry. It's called toad-like dry skin. Also called phrynoderma. Also called as phrynoderma. Then obviously there are going to be problems in the eye as well. Very important problems as far as eyes are concerned. What will happen in the eye? The first symptom when a child has vitamin A deficiency is night blindness. Remember, the first symptom when a child has vitamin A deficiency is night blindness. Well, the first sign will be what? Again, the drying. The same drying that I talked about. Epithelial integrity is not there. The epithelium is going to lose a lot of water. It's going to lose a lot of moisture. So first eye sign will be what? It will again be dryness. Which dryness? Conjunctiva dryness. Dryness of conjunctiva, which is also called conjunctival xerosis. Okay. Now, coming to what will happen as far as the WHO classification. Now coming to the WHO classification of vitamin A deficiency, which divides vitamin A deficiency into X1A, X1B, X2 and X3. X1A is what? The first sign that we discussed, drying of conjunctiva. X1A is nothing but conjunctival. It is nothing but conjunctival xerosis. In X1B, what's going to happen? The drying will result in formation of epithelial concretions. It will result in formation of these epithelial concretions, which are called Bitot spots. In X2, what's going to happen? After conjunctiva, cornea will become dry. So X2 is corneal xerosis. X2 is what? It is nothing but corneal xerosis. And X3, what happens after drying? Let's say our lips are chapped, they are dry. After a point of time, they will become what? They will ulcerate. The lips also ulcerate. So cornea is also going to ulcerate. So X3 is what? Corneal ulceration. X3 is what? Corneal ulceration. X3 is further divided into X3A and X3B. X3A is when less than 1/3 of the total surface area is involved. X3B is when more than 1/3 of the total surface area is involved. So this is as far as vitamin A deficiency is concerned. I really want to point out vitamin A is an amazing vitamin. It has a lot of therapeutic uses. Which you should remember. Two therapeutic use which you should remember, although it's a part, not exactly a part of pediatrics, a part of other subjects. One therapeutic use which you all have done, I personally have used, is when I had a lot of pimples. That is acne. The drug of choice for acne vulgaris is what? It is nothing but your retinoids. It's nothing but your vitamin A. So one important therapeutic use is what? It's acne. This is something which I have personally used. The second thing is also something which I have personally used, not for myself, but for my patients. So for those who know, I have done my DM in pediatric oncology, and vitamin A is a very important anti-neoplastic agent in one condition called APML. Acute promyelocytic leukemia, where the drug of choice is all trans retinoic acid. You must have done this in pathology. All trans retinoic acid, the drug of choice for acute promyelocytic leukemia. Why? How does it help? Remember, I told you the main function. Of vitamin A is what? Differentiation. It helps in differentiation. So in acute leukemia also, in acute promyelocytic leukemia, it will help in differentiation of those promyelocytes. The differentiation block will be taken care of. The myelocytes will mature into normal cells. So there also it acts like a differentiating agent. So two important therapeutic uses which you should remember: acne and APML. Also remember that vitamin A is teratogenic. That's why whenever a female is going to start using, it is teratogenic. That's why when a female is going to start using it for acne, let's say they're taking tablets of acne, it's always important to do a urine pregnancy test so that it doesn't become teratogenic to the baby inside. These are the things you should remember about vitamin A. Then we come to vitamin D. Vitamin D is what? It's your cholecalciferol. The scientific name is cholecalciferol. Vitamin D deficiency, what's the main function of vitamin D in our body? The main function, it is in the absorption of calcium and phosphate from the gut. Vitamin D helps in what? It helps in absorption of calcium and phosphate from the gut. And after absorbing this calcium and phosphate, when it comes into the bloodstream, it helps in deposition of this calcium and phosphate into the bones, resulting in healthy bone. Then it causes what? It causes the deposition of this calcium and phosphate into the bones. And this process is what is called as mineralization of bones. So what is the main function of vitamin D in our body? First, absorption of calcium phosphate from the gut, and then mineralization of bones. So what will happen in vitamin D deficiency? Rickets, which is basically nothing but defective mineralization of growing bones, Coming to the clinical features, the first sign in rickets is going to be craniotabes. It is what? Craniotabes. Also referred to as ping pong skull. What basically happens in craniotabes, I told you what's the main function of vitamin D in our body. It is calcification, it is mineralization, growing bones, bones becoming normally calcified, bones becoming strong in nature. So what will happen in craniotabes is that you will have one skull bone, another skull bone. They will not get properly mineralized, they will not get calcified. So there will be a lot of space between these skull bones, which ideally should have become calcified. So you'll have one skull bone here, one skull bone here. When you palpate it, you feel like there is one table tennis ball here, there is one table tennis ball here, which is basically called ping pong skull or craniotabes. That's the first clinical sign. Then we come to the lower limb changes. Remember, the lower limb changes will occur only after the child learns how to stand. That is at beyond 1 year of age. Beyond the 1 year of age. That's only when the lower limb changes will occur. Basically, the bones in the lower limb, they will not be able to get, they're not properly mineralized, they're not properly calcified, they don't have strength. So they won't be able to bear the weight of the upper part of the body and they will get deformed. But this deformation will only occur when the child learns how to stand. Then only those lower bones, bones in the lower extremities are going to get used, right? So the lower limb changes, remember, always occur at age more than 1 year. And what are these lower limb changes? There are two main changes that you should remember. The bones can deform in such a way that knees are knocking with each other. They're touching each other. This is what is called as knock knees. The other thing that they can become bow-shaped, which is called as bow leg. Both are occurring because the knees, they are not able to bear the weight of the upper part of the body. Knock knees and bow legs. Apart from this, there is a third deformity where it becomes something like this. Wind is coming and sweeping. This is called wind-swept deformity. This is called wind-swept deformities. Now, knock knees coming together is also called Gino-Val gum. It's also called as Gino-Val gum. Bow legs is also called as Genu varum. Bow legs is also called as Genu varum. How do you remember it? Knock knees. The knees are coming together. Jud gayi hai, they are joined together. What helps in joining? Gum helps in joining. That's why knock knees is Genu val gum. Okay? And the bow legs will obviously become Genu varum. So these are the lower limb changes you will see in rickets. Then coming to the chest changes. As far as chest changes are concerned, there are two changes you should remember. One is called the Harrison sulcus. Other is the rachitic rosary. So in Harrison sulcus, what's going to happen? The ribs, because they are not properly mineralized, when you take a deep breath, the ribs will not be able to maintain the structure of the rib cage, and basically everything will go inside. It will get deflected inside. That will result in a sulcus formation. Why? Because the ribs are not able to maintain the rib structure. Everything gets pushed inside. This results in sulcus formation called Harrison sulcus. Rachitic rosary is nothing but at the costochondral junction, there is cartilage. This cartilage ideally should be calcified. Calcium should get deposited. In case of rickets, what's going to happen? That calcification will not occur. So this costochondral junction cartilage will expand and will form a bead-like structure called rachitic rosary. So why does rachitic rosary occur? It occurs because of costochondral junction cartilage expansion. It will occur because of costochondral junction cartilage expansion. It will occur because of costochondral junction cartilage expansion. Now let's see what will happen as far as X-ray is concerned. What will happen in X-ray in rickets? So this will happen in X-ray in rickets. Because there is no proper calcification, the long end of the bone will become like this, saucer shaped. This is called as cupping. Then again, the growth will not be normal. Again, the growth is not going to be straightforward. So instead of growing straight like this, it will bend like this. This is called splaying. This is called cupping and splaying. The third thing that will occur is that towards these metaphyseal ends, there will be lack of calcification, some disorganized calcification. This will look like frizzled hair. This is called as fraying. So cupping, splaying and fraying. Three very characteristic signs of X-ray as far as rickets are concerned. But remember, the first sign is not this. The first sign is actually loss of calcification. And that's expected, right? Loss of calcification. That is the first sign, first X-ray sign as far as rickets is concerned. What will the lab investigations show? The lab investigation, calcium obviously is going to be what? calcium will be low. Calcium will be low because you're not absorbing calcium. When calcium becomes low, what happens? In response to calcium being low, PTH becomes high. So PTH will be what? PTH will be high. PTH will be high. When PTH becomes high, it will cause calcium to become normal. So calcium can be low or normal. It can be low or near normal. What will happen to phosphate? So phosphate will be low. You're not absorbing calcium, you're not absorbing phosphate also. And PTH also causes phosphate excretion. PTH, remember, is a phosphate uric hormone. PTH is a phosphate uric hormone. So PTH will cause phosphate excretion, and if there is vitamin D deficiency, you're not absorbing phosphate also. So phosphate always will be low. Phosphate always will be low. An alkaline phosphatase is a marker of PTH only. PTH does what? PTH goes to the bone, causes bony resorption. That bony resorption will release a lot of alkaline phosphatase. So this alkaline phosphatase will always be, this also will be high. Coming to the treatment, what we will do as far as treatment is concerned, you will give vitamin D. This vitamin D can be given in two manners. One is called the STOS regimen. Another is the low dose regimen. Treatment, STOS regimen and low dose regimen. In STOS regimen, you give 60,000 international unit of vitamin D every week for 10 weeks. While in the low dose regimen, you give 3 to 6,000 international unit every day for 3 months. Every day for 3 months. These are the two regimens which you can use. Remember, low dose regimen is the preferred regimen. Low dose regimen is the preferred regimen. Last fat soluble vitamin is your vitamin K. It's your vitamin K. Remember, vitamin K helps in gamma carboxylation of certain coagulation factor. It helps in gamma carboxylation of certain coagulation factors which are 2, 7, 9, 10. 2, 7, 9 and 10. These are the gamma carboxylation factors. These are the factors which require vitamin K for proper functioning. So obviously, if vitamin K is deficient, these factors will not be there. If these factors are not there, there will be a lot of lack of coagulation, will lead to a lot of bleeding. That's why this deficiency results in something called as hemorrhagic. It results in something called as hemorrhagic disease of newborn. Why specifically newborn? Because breast milk doesn't contain any vitamin K. This is why, why specifically in hemorrhagic disease of newborn? Why not other age groups? Because breast milk has no vitamin K. Because breast milk has no vitamin K. It is deficient in vitamin K. That is the reason we specifically end up having this hemorrhagic disease of newborn when there is vitamin K deficiency. Why? When does vitamin K deficiency occur? It particularly occurs in newborns because newborns will be drinking only milk. Milk will not have any vitamin K. So this is as far as your vitamins are concerned. This is as far as your vitamins are concerned. Now we move on to something very, very important. Malnutrition. First, we'll discuss the most severe form of malnutrition. That is your Kwashiorkor and marasmus. That is your Kwashiorkor and marasmus. That's what we are going to discuss. Just give me a moment. Exactly. Now we come to Kwashiorkor and marasmus. The main thing as far as Kwashiorkor and marasmus that you should take away from this lecture, if you've already attended my classes, you would already know this. But if you're someone who's watching this for the first time, this is the main takeaway that I always want to emphasize whenever I'm teaching Kwashiorkor and marasmus. It's a wrong concept that Kwashiorkor is protein deficiency and marasmus is calorie deficiency. It's a wrong concept that Kwashiorkor is protein deficiency and marasmus is calorie deficiency. For those who would have attended my lectures at some point or the other, either offline batches or in online batches, you would remember this concept very easily. This is a wrong concept that Kwashiorkor has protein deficiency while marasmus has calorie deficiency. It's a wrong concept. There is protein deficiency in both Kwashiorkor and marasmus. There is protein deficiency in both Kwashiorkor and marasmus. The only difference is from where the body is losing protein. The only difference is from where the body is losing protein. In Kwashiorkor, the body loses visceral protein. In Kwashiorkor, body loses visceral protein. What is visceral protein? Visceral protein is the protein which is there in liver, your albumin, the protein which is there in your enzymes, the protein which is there as far as neurotransmitters are concerned. In marasmus, the body loses somatic protein. Somatic protein is protein in the muscles. So there is protein loss in both the cases. The only difference is from where the body loses that protein. From which protein compartment does the body lose protein? In Kwashiorkor, there is visceral protein loss. In Kwashiorkor, there is visceral protein. What is visceral protein? Visceral protein is your albumin, it is your neurotransmitters, it is your enzymes. Well, as far as marasmus is concerned, marasmus, there will be loss of what? There will be loss of somatic protein. There will be loss of somatic protein. The protein which is there in muscles. The protein which is there in muscle. And that is the core difference between Kwashiorkor and marasmus. And that is the core difference between Kwashiorkor and marasmus. Kwashiorkor, you have visceral protein. You have albumin loss. If you have albumin loss, you will have edema. You will have water retention. If you have neurotransmitter loss, you will have the child will become very lethargic. He won't take any feeding. If you have enzyme loss, that will increase your risk of mortality. No enzymes, they are required for normal bodily function. They won't function. Child will die. In marasmus, there is muscle protein loss. So child will look very famished. There will be all loss of all the muscles from the body. The bones will start to get visible. The face will become what? Simian face. Because there will be loss of all the muscles and the fat from here. So face will become something like this. This is called simian face. So this is the core difference between Kwashiorkor and marasmus. Right? Kwashiorkor will have what? Bulging abdomen because of albumin loss. They will have facial edema. They will have facial edema resulting in a face called moon face. Moon face. Contrast this with marasmus. Marasmus will have loss of muscle mass, muscle protein loss, somatic protein loss. Face will become like this. There will be simian faces. It will be simian because of loss of fat, buccal pad of fat and muscle from here. Because of loss of buccal fat and muscle. Loss of buccal fat and muscle. This is the core difference. So let's write down the differences between Kwashiorkor and marasmus. And the spelling is given wrong here. This is marasmus. So wasting. What is wasted in Kwashiorkor? It is your visceral protein wasting. While there is somatic or muscle protein wasting as far as marasmus is concerned. Coming to appetite in Kwashiorkor, appetite as far as Kwashiorkor and marasmus is concerned. Kwashiorkor, no visceral protein, no neurotransmitters, child will be lethargic. If it's lethargic, it won't eat. So there is no appetite and child is lethargic in Kwashiorkor. In marasmus, child has neurotransmitters are there. In fact, child is not getting any food. So child will be very irritable. He wants food. So appetite is there and child is very irritable because what? Because he wants food. Age of onset, Kwashiorkor typically seen in age more than 1 year. Marasmus typically seen in age less than 1 year. Liver. Liver in Kwashiorkor will be fatty liver. There will be fatty liver in Kwashiorkor, while this fatty liver is not there in marasmus. Why fatty liver? Basically, the fats in the liver are transported to the rest of the body by lipoproteins. Lipoproteins are what? They're nothing but visceral protein. So lipoprotein also will get deficient in Kwashiorkor. So all the fat will be retained in the liver. It will not get transported where it is actually required. Retained in the liver because of lack of lipoprotein. That's why fatty liver. Coming to the appearance, I already told you there will be facial edema. So Kwashiorkor will have what? Moon-like facies. This is also called as fat sugar baby appearance. Called as fat sugar baby. It appears as though the baby has become fat because of taking a lot of sugar. Obviously, it is not fat. It is nothing but water. But as far as marasmus is concerned, I already told you, it will have simian facies and it will also have what is called as the baggy pant appearance. It will have the baggy pant appearance. Baggy pant appearance is seen at the level of buttocks, where all the fat, when all the muscles will be lost, it will appear as if there will be hanging of skin, which is called baggy pant appearance. Prognosis, obviously, Kwashiorkor visceral protein is much more important. Your albumin, your neurotransmitter enzymes are much more important for your survival than muscle protein. So prognosis is going to be poor in Kwashiorkor. It's going to be better in case of marasmus. Child is not eating. How will you ensure that he comes out of Kwashiorkor in case of Kwashiorkor? Poor prognosis in Kwashiorkor, better prognosis as far as marasmus is concerned. Additional features as far as kwashiorkor, because enzymes are not there, enzymes which are required for your skin melanin synthesis, melanin skin and hair, they also will be deficient. So there will be skin and hair changes. What skin and hair changes are seen? You will have flaky pain dermatosis, and you will have flag sign. Basically, the hair will be something like this. One patch of hair black, then white because no melanin, then again black. This is what is called as the flag sign. This obviously, these skin and hair changes are not seen in marasmus. The skin, flaky pain dermatosis, flag sign, this is not seen in marasmus. Then we come to malnutrition. Acute and chronic malnutrition. Acute and chronic malnutrition. Now, as far as acute malnutrition is concerned, remember the best method, the best way you can judge acute malnutrition is weight for length. The best way you can judge chronic malnutrition is height for age. It is what? It is height for age. Now, whenever this weight for length is less than -2 standard deviation, we'll call it as moderate acute malnutrition. We'll call it as moderate acute malnutrition. If this weight for length is even lower, less than -3 standard deviation, we'll call it as severe acute malnutrition, or SAM. As far as chronic malnutrition is concerned, if the height for age is less than -2 standard deviation, we'll call it as moderate chronic malnutrition. If the height for age is further lower than -3 standard deviation, we'll call it as severe chronic malnutrition. So now, we discussed in the very beginning of the class that acutely we need to use something which is weight based. Chronically, we need to use something which is length based. Suddenly, if you are not taking your food for 1 month, 2 months, what is going to fall first? It's your weight which is going to fall first. So in acute malnutrition, you need to use a weight based parameter. We are using a weight for length. But for that length, the weight has reduced drastically. So for acute malnutrition, we are using a weight based parameter, weight for length. Well, as far as chronic malnutrition is concerned, chronically what is affected? It's your height which is affected. That over a period of time, the height will not grow at all. It won't be affected in acute malnutrition because the differences in 1 month time are minimal. But chronically, it is your height which is affected. That's why height for age is used for chronic malnutrition. Now, acute malnutrition is also known as wasting. While chronic malnutrition is also known as stunting. It is also known as stunting. What I basically mean to say, let's say a child has a weight for length less than -2 standard deviation. Let's say the weight for length is less than -2 standard deviation. You can call it as moderate acute malnutrition. What is another term for acute malnutrition? Wasting. You can also call it as moderate wasting. Similarly, if the weight for length is less than -3 standard deviation, further lower, severe acute malnutrition or severe wasting. You can also call it as severe wasting. Same goes for height for age. If the height for age is less than -2 standard deviation, we call it as moderate chronic malnutrition. You can also call it moderate stunting. If the height for age is less than -3 standard deviation, you call it as severe chronic malnutrition. You can also call it as severe stunting. So chronic malnutrition is basically also called as stunting. Acute malnutrition is also called as wasting. Now there is one parameter which I did not discuss, that was weight for age. Now weight for age is a parameter which can be used for both acute and chronic malnutrition. It can be used for both acute and chronic malnutrition. Because it can be used for both acute and chronic malnutrition, it is not the best parameter for either of them. It is not the best parameter for either of them. Since it's being used in both, it can be low in both. So when it is low, you don't know whether it is acute malnutrition or chronic malnutrition. We want something which is specific for that. Height for age is decreased only in chronic malnutrition. Weight for length is decreased only in acute malnutrition. Weight for age can be low in both. Because it can be low in both, we don't use it for both of them. We don't use it for either of them. When the child's weight for age is less than -2 standard deviation, we call the child as underweight. No acute malnutrition, no chronic malnutrition, we call it as underweight. You can never define acute malnutrition with weight for age. You can never define chronic malnutrition with weight for age. Can be used for both, but it is not the best parameter for either of them. Whenever the weight for age is low, you don't use the term acute and chronic malnutrition. You use the term what? Underweight. When the weight for age is less than -2 standard deviation, you call the child as underweight. You call the child as underweight. Less than -2, moderately underweight. Less than -3, severely underweight. That thing will stay the same. If it is less than -2, it is moderately underweight. Moderately underweight. If it is less than -3, child will be severely underweight. That thing stays the same. Let's learn this with the help of an example. Let's see a first scenario. In this scenario, example 1, first scenario, there was a 2-year-old child. There is a 2-year-old child whose weight is 12 kg and height is 88 centimeter. Now, after 1 month, let's say the child did not take any food at all in this 1 month. Let's say the child did not take any food at all. In this 1 month. Weight obviously will fall. So at 2 year 1 month age, child has become 10 kg, but height is still the same, 88 centimeter. Now tell me here, what will happen to weight for length in this first scenario? This is acute malnutrition scenario. 1 month child did not take anything, weight has fallen. What has happened to weight for length? Tell me what has happened to weight for length. Decreased, exactly. Weight for length will be decreased. Right? For 88 centimeter length, the weight should be 12 kg. Now for 88 centimeter length, weight has decreased. The 10 kg weight is less for that 88 centimeter length. What will happen to weight for age? Weight for age will also decrease. A 2-year-old child, 1 month old child with 12 kg. Now a 2-year-old child is only 10 kgs. Weight for that age has decreased. But the height for age is normal. The height for age is normal. A 2-year-old child is 88 centimeter. 2-year 1 month old child 88 centimeter. More or less normal. So in acute malnutrition, weight for length decreases, weight for age decreases, but height for age stays normal. That's why in acute malnutrition, you can only use weight for length or weight for age. First of all, you cannot use height for age. Height for age is only for chronic malnutrition. Let's see the second scenario. That is chronic malnutrition. In this case, let's say for 1 year, child did not take anything. 12 kg child, 88 centimeter at 2 years. For 1 year, he did not take anything. After 1 year, he stayed 12 kg. Child stayed 12 kg. Child stayed 88 centimeter. He has not gained any weight. He has not gained any height also. Now the child is 3 years old. His weight is also 12 kg. His height is also 88 centimeter only. Now what has happened to his weight for age? Weight for age has decreased. See, a 2-year-old child being 12 kg is fine, but a 3-year-old child being 12 kg, low. What has happened to his height for age? Again, height for age has also decreased. A 2-year-old child being 88 centimeter is fine, but 3-year-old child should be 94 centimeter. Now a 3-year-old child is only 88 centimeters. Height for that age has decreased. But if you look at weight for length, the ratio is still the same. That 88 centimeter child is still 12 kg. Weight for that length, that 12 kg weight for that 88 centimeter length, that ratio is still the same. So weight for length in chronic malnutrition is normal. It is what? It is normal. Weight for length is normal. With this scenario, can you understand? In the parameter which decreases only in chronic malnutrition. The parameter which decreases only in chronic malnutrition is your height for age. Height for age decreases only in chronic malnutrition. It does not decrease in acute malnutrition. The parameter which decreases only in acute malnutrition. The parameter which decreases only in acute malnutrition is weight for length. It stays normal in chronic malnutrition. The parameter which decreases in both. The parameter which decreases in both is weight for age. Because weight for age is decreasing in both, we don't know whether it is acute or chronic malnutrition. Because weight for age is decreasing in both, it is not the best parameter for either of them. We want something which is specific. So in acute malnutrition, the one thing which only decreases in acute malnutrition is weight for length. The thing which decreases only in acute malnutrition is weight for length. The thing which decreases only in chronic malnutrition is height for age. It is your height for age. It is your height for age. So one thing which decreases only in acute malnutrition, weight for length. That's why we use weight for length for defining acute malnutrition. The one thing which decreases only in chronic malnutrition, it is your height for age. Weight for length decreases only in acute malnutrition. Height for age decreases only in chronic malnutrition. That's why when the weight for length is less than -2, moderate acute malnutrition. When the weight for length is less than -3, severe acute malnutrition. Acute malnutrition is also called, wasting. Chronic malnutrition is also called stunting. We'll do 2 MCQs. I'll discuss 2 MCQs. After that, we'll take break. We'll discuss 2 MCQs. After that, we'll take a small break. Tell me the answer to this question. A 2-year-old child What is the answer to this question? Now tell me, first of all, I told you very clearly, you will define acute malnutrition with what? Weight for length. You will never use weight for age for acute malnutrition. Weight for age is only for what? Underweight. Weight for age can be used for both, but it's not the best parameter for either of them. Look here. Height for age is less than -2.3. What is it? Chronic malnutrition. Height for age is less than -2.3. So this will be moderate chronic malnutrition. Weight for age is -2.3. Moderately underweight. Can you define acute malnutrition? No. This is moderately underweight. Weight for length is normal between +2 and -2. It's not less than -2. So weight for length is normal. There is no acute malnutrition. There is no acute malnutrition. I told you weight for age can be low in both. In this case, when the weight for age is low, it is low because of chronic malnutrition. Here, the weight for age is low because of chronic malnutrition. This is not acute malnutrition. This is chronic malnutrition. This is chronic malnutrition. It is not severe stunting. Why? Why is it not severe stunting? Because it is not less than -3. It is not acute malnutrition. It is not severe acute malnutrition. It is not severe stunting. It is only chronic malnutrition. Or moderate chronic malnutrition would have been a better answer, but that is not there. That's why the answer is chronic malnutrition. That's why the answer is chronic malnutrition. That's why the answer is chronic malnutrition. I told you, remember this very clearly, write it down. Weight for age is never used for defining of either acute or chronic malnutrition. Weight for age can be low in both. Weight for age can be low in both, but it is never used to define acute and chronic malnutrition. Always remember that. You are looking only at weight for age. I told you weight for age can be low in both acute and chronic malnutrition. I told you it can be low in both acute. So you have to specifically look whether the height for age has decreased or weight for length has decreased. In this scenario, height for age had decreased, so it was chronic malnutrition. Weight for length was normal, so it was not acute malnutrition. It was not acute malnutrition. The best way to deal all this question is for every parameter, write down the interpretation. For every parameter, write down the interpretation. Let's take another question. Let's take another question so that this concept is drilled into your mind. So that this concept is drilled into your mind. You have a child, a 2-year-old child. What will be the answer here? Exactly. Now the answer will be D. Now the answer will be D. Now you're getting it. See, weight for length is minus 2.3. This is moderate acute malnutrition or moderate wasting. Wasting and acute malnutrition is same. Weight for age is minus 2.7. So it is moderate underweight. It is moderate underweight. And height for age is, this is normal. So there is no stunting, no chronic malnutrition. Severe stunting, no. There is no stunting. Height for age is normal. Severe chronic malnutrition, no. Is it SAM? No, it is moderate acute malnutrition. So this is also wrong. Answer is going to be simple. It is acute malnutrition. Both moderate and acute, severe acute malnutrition, both are acute malnutrition only. So answer will be acute malnutrition. Let's take another question. Let's take one more question. Let's take one more question. What is the answer here? What is the answer here? Exactly. Answer will be D. This is stunting. For these kind of questions, I would simply advise you for each parameter, write down the interpretation. So weight for length is normal. Normal weight for length means no acute malnutrition. No acute malnutrition or no wasting. No acute malnutrition or no wasting. Weight for age is minus 3.7. So this means severely underweight. Weight for age is low, less than minus 3. Severely underweight. Severe underweight. Height for age minus 3.3. Severe chronic malnutrition, also called severe stunting or simple stunting. Acute malnourished, no. Weight for length is normal. Moderately underweight, no. Severely underweight, wrong. Wasted, no. There is no acute malnutrition, no wasting. The only answer is stunting. Only answer is stunting. Only answer is stunting. Everyone understood the concept? Everyone understood the concept? Most of you are writing it correct now. Now everyone is writing it correct. For every parameter, the simple way to do this is for every parameter, write down the interpretation. Always remember, weight for age is never used to define either acute or malnutrition or chronic malnutrition. Always remember, weight for age is never used. Although it can be low in both. I explained it to you that it can be low in both. But it is never used to define either acute and chronic malnutrition because it can be low in both. So how do you differentiate? It is never used for acute or chronic malnutrition. Weight for age means only underweight. Weight for age means only underweight. Weight for age means only underweight. Alright. What is acute and chronic malnutrition? Very interesting question. The next question I was going to give you this only. Let's see. Now what will be the answer? Exactly. When both, here, let's write down the interpretation everywhere. Weight for age is minus 2.1. Weight for age is minus 2.1. So this is underweight. Moderately underweight. Weight for length is minus 2.7. So this is what? This is moderate acute malnutrition. This is moderate acute malnutrition. Height for age is minus 2.3. So this is moderate chronic malnutrition. So when both weight for length and height for age is decreased, in this scenario, both weight for length and height for age is decreased. This is acute on chronic malnutrition. This is acute on chronic malnutrition. This is acute on chronic malnutrition. Right? So this is acute on chronic malnutrition. So everyone has understood the context. So everyone has understood the concept. This is acute when weight for length and height for age both are reduced. That is acute on chronic malnutrition. Let's take a 15 minutes break now. Hi. Chalo, let's start again. So we discussed about acute and chronic malnutrition. I told you acute malnutrition is defined using weight for length. Chronic malnutrition is defined using height for age. Done. Now let's come to severe acute malnutrition specifically. Let's come to SAM. That is your severe acute malnutrition specifically. Now the definition of SAM includes any one of the following. The actual definition of SAM includes any one of the following. Out of these three things, any one of the following will say the child is having SAM. What are these three things? First, we already discussed when the weight for length is less than minus 3 standard deviation. Second thing we also discussed, the mid upper arm circumference. Remember, less than 11.5 centimeter, I told you it would be SAM. When the mid upper arm circumference is less than 11.5 centimeter. But remember, this definition of mid upper arm circumference being less than 11.5 centimeter is used only in children between 6 months to 5 years. We don't use it for children less than 6 months. Remember that. Or if there is bipedal nutritional edema, or a fourth point also, if there is visible severe wasting. So these are the four criteria as far as SAM. These are the four criteria as far as SAM is concerned. If any one of the following is said to be there, we will call the child as being having what? SAM. Child will be said to be as having SAM. Now, the first two are something which we already discussed. If the mid upper arm circumference is less than 11.5 centimeter, weight for length is less than minus 3 standard deviation, we'll call it as SAM. We already know. Why is this bipedal nutritional edema and visible severe wasting there? It is there to ensure that Kwashiorkor and marasmus is also always called as SAM. See, in Kwashiorkor, what is going to happen? In Kwashiorkor, you are going to gain weight. In Kwashiorkor, because of water retention, you might actually gain weight. If you actually end up gaining weight, what's going to happen? The weight for length will be normal. And even the mid upper arm circumference might also turn out to be normal. And you will say the Kwashiorkor child is a normal child. So in order to prevent that, and in short, Kwashiorkor is the severest form of protein energy malnutrition, highest risk of mortality, highest risk of death, right? In order to prevent that, that's why we added this bipedal nutritional edema. that every child who has Kwashiorkor is always classified as having severe acute malnutrition. And that's why we added this visible severe wasting also, that every child who has marasmus also is classified as having severe acute malnutrition. So what is severe acute malnutrition? Any one of the following: weight for length less than -3 standard deviation, mid upper arm circumference less than 11.5 centimeter, bipedal nutrition edema, or visible severe wasting. Coming to the management of SAM. As far as SAM management is concerned, I'll write down just the 10 steps of management of SAM are important. And in what phases they are done is what is important. So you have to understand SAM, when a child who has come to you with SAM, he is very sick. Severe acute malnutrition. That's why it's called severe acute malnutrition. So the management of SAM is actually done in 2 phases. The first phase is called the stabilization phase, which lasts for 7 days. And beyond 7 days, you have the rehabilitative phase. Beyond 7 days, you have the rehabilitative phase. The concept basically goes that in the first 7 days, the goal is not suddenly to give him a lot of calories, lot of protein so that he grows back and then, his weight comes back and height comes back. No. The first 7 days, you stabilize the child. You ensure the child doesn't die. Marna nahi chahiye. In the first 7 days, the goal is child doesn't die. You stabilize, ensure all the complications are taken care of. Child doesn't die of complications. After 7 days, you build up the child again. This is the basic concept of the stabilization and the rehabilitative phase. Now, what are the 10 steps of management of SAM and what are the complications of SAM? They are covered in one and the same thing. The first complication is hypoglycemia. The first complication is hypoglycemia. So hypoglycemia obviously can immediately kill the child. You will do it in the stabilization phase. So hypoglycemia is managed over the first 3 days itself. It's managed over the first 3 days itself. Then you can also have hypothermia. Hypothermia is also managed within the first 3 days itself. Hypoglycemia is defined as blood sugar less than 54. Hypothermia is defined as temperature less than 35.5 degrees Celsius measured at rectum. Then dehydration can also immediately kill the child. That's why it's also managed over the first 3 days itself. Then all these children who are malnourished, obviously their defenses, the body defenses, immunity will be down. They'll be having an infection. Infection is a complication, can immediately kill the child, but you cannot manage an infection in 3 days. You need to give at least 1 week of IV antibiotic. So it's managed over 7 days. You need to give at least 1 week of IV antibiotic. Which IV antibiotic do you give? You give ampicillin plus gentamicin. And remember, it's always the gram-negative organisms which are more common. Then these children can also have electrolyte disturbances, electrolyte imbalance. Now, electrolyte imbalance obviously needs to start to be managed in the initial phases itself, and you will keep on replenishing them all the way till the end of the end of rehabilitative phase itself. Which electrolytes are deficient? They typically tend to have hypokalemia and hypomagnesemia. So you will supplement magnesium and you supplement potassium. Then they can have micronutrient deficiencies. For this, you'll give all the micronutrients, folate, zinc, iron, everything. But very important thing, all this supplementation of these micronutrients, in the first week, you will never give iron. Only beyond the first week, you will give iron. In the first week, you never give iron. Why don't you give iron in the first week? Because iron is known to stimulate the formation of reactive oxygen species. Child is already having infection. Those are also making reactive oxygen species. Reactive oxygen species, death. So iron in the first week will increase reactive oxygen species, which can contribute to mortality and death. That's why in the first week, you will never give iron. Very important. No iron in the first week of SAM management. Then in the first week, you will do what is called as cautious refeeding. For the first week, for which we use F75. It's called F75 because it has 75 kilocalorie per 100 ml. After the first week, you'll increase the calories, which is called catch-up growth, Now you'll use F100, which basically has 100 kilocalorie per 100 ml. Then you should ensure a proper environment, a loving and nurturing and caring environment. Love and caring environment should be there throughout the management. And then obviously a follow-up. I have one question for you. In the first week, we give low calorie food. Beyond the second week only, we give high calorie food. Child is malnourished. Why don't we give high calorie food in the first week itself? Why do we start from this F75? Why do we do cautious refeeding? Why is cautious refeeding done? What is the reason for cautious refeeding? Tell me in the comment section. I know a lot of you would already know this. Exactly. It is done to prevent refeeding syndrome. That's why the name itself is cautious refeeding. Why is there cautious refeeding? To prevent refeeding syndrome. It is done to prevent refeeding syndrome. What is this refeeding syndrome? See, in the first week, if you give a very high calorie food, let's say you give this 100 kilocalorie, you give very high, high calorie food. What will happen? That will lead to excess insulin. Calorie, whenever sugar is there, excess sugar in there in the body, insulin go high. This excess insulin will do what? This excess insulin will transport all the potassium into the cell, all the phosphate into the cell, leading to all the potassium into the cell and all the phosphate into the cell, leading to hypokalemia and hypophosphatemia. This hypokalemia and hypophosphatemia is what is called as refeeding syndrome. This is what is called as refeeding syndrome, this hypokalemia and hypophosphatemia. If they ask you amongst hypokalemia and hypophosphatemia, which is a better marker, which is the hallmark, then the answer is going to be hypophosphatemia. Remember, hypophosphatemia is the hallmark of refeeding syndrome. So this is as far as SAM is concerned. What is the definition of SAM? Repeating it just one more time. Any one of the following, if it is there, you will call the child as having SAM. If the weight for length, remember, acute malnutrition is defined only by weight for length, never by weight for age. In fact, this is the question which they keep on asking, repeating in INI CET. They will give you which of the following is not SAM. And one of the options will be weight for age. Weight for age is never used to define SAM. Keep this in your mind. Weight for age, height for age are never used to define SAM. What is the definition of SAM? Weight for length less than -3 standard deviation, mid-upper arm circumference less than 11.5, child having bipedal nutrition edema. To ensure Kwashiorkor is always called SAM, or having visible severe wasting, to ensure marasmus is always called as SAM. The mid-upper arm circumference MUSC is used only in 6 months to 5-year-old children. Management includes 2 phases, stabilization and rehabilitative. First 7 days, stabilization. After 7 days, you rehabilitate. First 7 days, don't let the child die, stabilize the child. Okay, what are the 10 steps of management of SAM? Hypoglycemia managed in first 3 days. Hypothermia managed in the first 3 days. Dehydration managed in the first 3 days. Infection takes 7 weeks. Give 1 week of IV antibiotics, ampicillin, gentamicin. Most infections are gram negative. Electrolyte imbalance. Which electrolyte imbalance can occur? Hypokalemia, hypomagnesemia. Supplement those. Micronutrient deficiency. You'll supplement every micronutrient. Never give iron in first week. Iron only after first week. You do cautious refeeding to prevent the refeeding syndrome. After that, you do catch-up growth with F100. So this is as far as management of SAM is concerned. Always remember this: hypoglycemia, hypothermia, and infection occur in a triad. This is the triad of SAM: hypoglycemia, hypothermia, and infection. This is the triad of SAM. Hypoglycemia, hypothermia, and infection is the triad of SAM. Just remember that. With this, we have completed malnutrition. With this, we have completed malnutrition. Now coming to milestones. Now we'll come to milestones. That is development. We'll come to development and we'll come to milestones. We have completed nutrition. We have completed growth. We are coming now to milestones. Now, as far as milestones are concerned, first we'll start with gross motor milestones. Now, gross motor milestones you can easily remember with the help of this stick figure. This is nothing but your knees. and this is your feet. This is your trunk, and this is your neck. This is your neck. Make this stick figure, and then just write 3, 6, 9, 12. This will make all the gross motor milestones very easy. At 3 months, you will have neck control. At 3 months, you will have what? You will have neck control. At 6 months, you will have trunk control. If you start to have trunk control, what will happen? You will be able to sit with support. If there is trunk control, you will be able to sit with support. When the child sits with support, he sits like this. He sits like this. This is also called tripod position. He sits like this, holding both his hands on the floor. He sits. This is what is 2 here and his trunk, tripod position. At 9 months, the knees will start to gain function. So at 9 months, you will be able to stand with support. At 9 months, you are able to stand with support. At 12 months, you will be able to, feet is now strong enough. You will be able to walk with support. You will be able to do what? You will be able to walk with support. Neck control, trunk control, sits with support, knee control 9 months, stand with support, 12 months, feet control, walk with support. Very simple. Now, if at 9 months you are standing with support, you should already learn sitting without support. So sitting without support will occur a little prior at 8 months. So at 8 months you will have sitting without support. Eight months you'll have a little prior, you'll have sitting without support. At 12 months, if you're having walking with support, standing without support should occur a little prior at 11 months, right? So standing without support actually occurs at 11 to 12 months. We write it at 12 months only. At 11 to 12 months, let's write it here in the 12 months one only. And at 11 to 12 months, you will be standing without support. So some people write 12 months as standing without support and walking with support Simple, right? Apart from this, you should also remember 2 other things: crawling and creeping. Crawling is when the baby is on all fours. And what does a snake do? What does a reptile do? They crawl. All the reptiles crawl. So when the snake is moving, his abdomen is touching the ground. The same thing is valid as far as crawling in a baby is concerned. When he's on all fours and is moving across the ground and his abdomen is touching the ground, that is called crawling. Crawling appears at 8 months. At 8 months, you will have crawling. At 10 months, you will have creeping. At 8 months, you will have creeping. Creeping is when the child is on all fours, but abdomen is not touching the ground. Crawling also has A. That's how you can remember. Crawling means abdomen is touching the ground. Along with creeping, another CR thing occurs called cruising. Creeping occurs along with something called as cruising. It occurs with something called as cruising. What is cruising? At 9 months, child is standing with support. He's, let's say he's standing with support like this. At 10 months, he'll move 1 foot towards sideways. So he will move along the furniture. He's still standing with support. He will move along the furniture. The sideways movement along the furniture is called as cruising. This comes at 10 months of age. It's very simple. 3, 6, 9, 12. At 3 months, the child is able to neck control, 6 months, trunk control, sit with support, 9 months, stand with support, 12 months, walk with support. If at 9 months, child is able to stand with support, at 8 months, child should be able to sit independently. At 12 months, if the child is able to walk with support, at 11 to 12 months, child should be able to stand independently, that is stand without support. Right? 8 months crawling, 10 months creeping. Creeping comes with another scr wala sound, cruising. 8 months crawling, 10 months creeping and cruising. After that, it's very easy. After that, it's even easier. What did Bunny say to Naina in Ye Jawani Hai Diwani? Bunny ने क्या बोला था? मैं चलना चाहता हूं, मैं दौड़ना चाहता हूं, मैं उड़ना चाहता हूं. चलना चाहता हूं, मैं दौड़ना चाहता हूं, मैं उड़ना चाहता हूं. Baby will do the same also. Baby will walk, baby will run, and baby will fly. Fly तो नहीं करेगा obviously, baby won't fly. So what does the baby do? Baby goes up and down stairs. Baby goes up and down stairs. So at 15 months, child learns how to walk. At 18 months, child learns how to run. At 2 years, child is able to go up and down stairs. Initially, when the child goes up and down stairs, how it goes, when he's going upstairs, he'll put one feet here and he'll put the same feet on the same step. When he's going again upstairs, one feet on that step, another feet on that step itself. So he's going up and down stairs using 2 feet per step or 2 feet per time. At 3 years of age, 3 has 3 in it. Tricycle also has 3 in it. Try. Child will be able to use a tricycle. Child will be able to use a tricycle. At 3 years of age, child will be able to go upstairs using 1 feet, but downstairs he'll come back still using 2 feet. He'll be able to go upstairs using 1 feet, but downstairs he'll still come back using 2 feet. Why? Because going downstairs is a tougher task as compared to upstairs. Because going downstairs, child will be afraid he might fall. He doesn't have that stability. That developmental maturation hasn't come. So when he's going upstairs, he'll be using 1 feet, like normally we do. 1 feet on one step, then another feet on another step, like that. But downstairs, he's scared that if he does this 1 feet at a time, he might fall. He might fall. And that developmental maturation, that developmental stability hasn't come. So at 3 years, upstairs 1 feet, but downstairs still 2 feet. At 4 years of age, he finally will be able to go both upstairs and downstairs, 1 feet per step. Both upstairs and downstairs, 1 feet per step. Now, 4 has 4 in it. 4 has 4 in it. Hops also has 4 letters in it. So, child will be able to hop. 5 has 5 in it. Skips also has 5 letters in it. So, child will be able to skip. So child starts hopping at 4 years, child starts skipping at 5 years. This is as far as gross motor milestones are concerned. 3, 6, 9, 12. Neck control, sit with support, stand with support, walk with support. 12 months, walk with support. If 12 months he's walking with support, he should be stand independently at 11 to 12 months. After 12 months, मैं चलना चाहता हूँ, मैं दौड़ना चाहता हूँ, उड़ना चाहता हूँ. 15 months walk, 18 months run, 2 years उड़ना, up and down stairs, 2 feet. 3 years, upstairs 1 feet, downstairs still 2 feet. Downstairs, still 2 feet. 3 has 3 in it. Tricycle. 4 has 4 in it. Hops has 4 in it. Hops. 5 has 5 in it. Skips has 5 in it. Skips has 5 letters in it. Done. Gross motor milestones are done. That's it. These are the most important gross motor milestones. Now we come to fine motor milestones. Now, as far as fine motor milestones are concerned, the first fine motor milestone is at 3 months, what will happen? Child will bring both the hands into midline. He'll look at both the hands into midline. He'll look at both the hands intently, recognizes his own hands. This is what is also called as hand regard. So at 3 months, child will bring both the hands into midline and will also develop what is called as hand regard. Hand regard is sometimes considered a social milestone, but I usually like to write it down here itself. Brings both the hands into midline, looks at them intently, hand regard. At 4 months, what's going to happen? Let's say there is a small object, a small ball. There's a small ball on top of the baby. He'll try to grasp it using both his hands. This is called bidextrous grip. Or bidextrous grasp. But remember, when he tries to grip it, he won't be able to catch it. Either he'll overshoot or he will undershoot. So, but unable to grasp. Unable to do it because there is overshooting or undershooting. At 5 months, finally, he will be able to grasp. There is a proper bidextrous grasp with no overshooting. At 5 months. At 6 months, what's going to happen? Let's say there is an object in front of the baby. There's some object in front of the baby. Let's say this can is there, something like this. Now he'll try to use a single hand to grasp it. But when he grasps this single hand, normally if I want to pick it up, I'll pick it up like this. This is what we'll do, or we'll use this. We're using the radial aspect of the hand. Baby won't do that. At 6 months, baby will use the ulnar aspect of the hand to pick it up like this. So this is called ulnar grasp. It's a type of unidextrous grasp. But 6 months, the unidextrous grasp. At 6 months, the unidextrous grasp start. But it is ulnar in nature. At 7 months, finally, child will be able to do what is called as, we'll be able to pick something from the radial aspect. So radial grasp. So radial grasp. So radial grasp will start at 7 months. See, at 7 months, if the child has used radial aspect to hold something, at 7 to 8 months, he'll transfer this thing from one hand to another. So transfer of objects also starts at 7 to 8 months. So at 7 to 8 months, you will also witness transfer of objects from one hand to another. You will also witness transfer of objects from one hand to another. Now, after this, now you're using the entire radial aspect. When I'm holding this, now I'm going to talk about something called as pincer grasp. So what happens in pincer grasp? Let's assume this is a pencil. This is a pen or a pencil. When the baby is holding it and putting it up like this, using only the index finger and the thumb finger, putting it up like this, only index and thumb finger. This is what is called as pincer grasp, mature pincer grasp. You're using only the index and the thumb finger, like this. But let's say baby uses something like this. Now you're mainly using index and thumb finger, but you're taking some support of the middle finger as well. This is called immature pincer grasp. So at 9 months comes the immature pincer grasp. At 12 months will come mature pincer grasp. At 12 months will come mature pincer grasp. Now at 12 months, child has picked up this. So at 15 months, he'll start to put it on the table and do like this. This is called scribbling. So at 15 months comes scribbling. At 15 months comes what? Scribbling comes. At 15 months, scribbling comes. After 15 months, now after scribbling, child will start to draw something. So let's learn the drawing skills of the child. At 2 years, 2 points. 2 years, 2 points. Child is able to draw a line between 2 points. At 3 years, child is able to make a circle. How can you remember it? A circle is there in a 3. At 4 years, child is able to make a cross. How can you remember? Cross has a 4 in it. At 4.5 years, child will be able to make a square or a rectangle. At 5 years, child is able to make a triangle. How do you remember this? 5 has a triangle in it. Let's see. So at 5 years, child is able to make a triangle. At 6 to 7 years, see 7 has 7 in it. Diamond also has 7 letters in it. So at 6 to 7 years, child is able to make a diamond. At 9 years, child is able to make a cylinder. How do you remember? Again, cylinder has a 9 in it. And finally, at 11 years, child will be able to make a cube or a cuboid. How do you remember? Again, a cube or cuboid has 11 in it. So these are some important drawing skills as far as a child is concerned. Coming to dressing and undressing. Now, as far as dressing and undressing is concerned, you should all know this evolutionarily. We're not supposed to have these clothes. We're supposed to be naked. Imagine yourself in an empty room with your boyfriend or a girlfriend. Will you put on clothes or will you remove clothes? Of course, I hope you guys remove clothes. The baseline concept being that evolutionary, we are bound to be in an undressed manner rather being in a dressed manner. The same is true as far as dressing and undressing is concerned. Undressing will come earlier because we want to be undressed. Evolutionary humans want to be undressed. Dressing will come later. So child is able to undress with help. Child is able to undress with help at 2 years of age, while the child will be able to dress with help at 3 years of age. Now, if the child is able to dress with help, child should be able to undress without any help at 3 years of age itself. So, child is able to undress without help at 3 years of age itself. Undress without any help at 3 years of age itself. Then, child is able to button himself up at 4 years of age, and child is able to dress fully without any help. This includes the shoelaces as well. Dress fully without help at 5 years of age. At 5 years of age. So this is as far as dressing and undressing is concerned. This is as far as dressing and undressing is concerned. Now we come to social milestones. Now, as far as social milestones are concerned, at 2 months, what will start? Social smile will start. Basically, the baby will look at someone new faces, smile. This is what is called as social smile. So at 2 months, social smile will start. Now at 3 months, what's going to start? At 3 months, so I told you the baby puts the hands into midline, looks at the hands, hand regard. If he's able to recognize his own hands, he should be able to recognize his own mother as well. So at 3 months, child is able to recognize his own mother. At 6 months, 6 has 6 in it. 6 has 6 in it. Mirror also has 6 letters in it. Mirror also has 6 letters in it. So at 6 months, child will do what is called as mirror play. What is mirror play? Child will sit in front of the mirror, recognize his own reflection and play with that reflection. So if you put it in front of a mirror, he'll see that reflection, laugh at that reflection and play with that reflection, which is called mirror play. Then at 7 months, 7 has 7 in it. Anxiety also has 7 letters in it. ANXIETY. 1, 2, 3, 4, 5, 6, 7. Anxiety also has 7 letters in it. So at 7 months, stranger anxiety will start. Stranger anxiety will start. At 9 months, 9 has 9 in it. Bye, bye, bye. Bye, bye, bye. This also has 9 letters in it. This also has 9 letters. So child will wave bye bye. Child will wave bye bye at 9 months of age. Another thing has 9 letters in it. Another thing has 9 letters in it. Permanent has 9 letters in it. Permanent has 9 letters in it. So at 9 months, object permanence will start. Object permanence will start. What is object permanence? Prior to 9 months, let's say there was a toy in front of a baby. There was some toy in front of a baby. Prior to 9 months, you take the toy back. Child will be unbothered. Out of sight, out of mind. But after 9 months, if you take the toy back, child will look around. Kahan gaya? Because now that object is permanent in his mind. Now he knows if you have hit the object. It cannot just disappear like that. This is called object permanence. This starts at 9 months of age. At 1 year of age, child will play simple ball game. 2 years of age, you will have two parallel lines. Child will have what is called as parallel play. Child will have what is called as parallel play. What is parallel play? Basically, in a room, if you have two children, one child with his set of toys, another child with his set of toys, these two children will not play with each other. They will play parallelly. In a room, you can put 2-3 children. All children will play independently of other children. They will not play with each other. They will play with their own toys. This is called parallel play. At 3 years, this will turn into cooperative play. At 3 years, this will turn into cooperative play. They will start to play with each other. At 4 years, finally, this will turn into what is called as role play. What is role play? Role play is something which adults also do, which is there for the boys, especially the plumber, the astronauts and everything. Just joking, just kidding. What is role play? Basically, the children will assume multiple roles, right? One child will become police, other child will become thief. Ghar ghar khelte the. We used to play home home. One child will become husband, another child will become wife. Things like that. That is what is called as role play. That is what is called as role play. This will start at 4 years of age. This will start at 4 years of age. At 4 years of age, another thing will start. That is your group play. Another thing will start. That is your group play. That is your group play. This completes your social milestones. Now we come to language milestones. Language milestones. At 2 months, you will have what is called as vocalization. Vocalization starts. At 2 months, what will start? Vocalization will start. At 3 months, child will do what is called as cooing. So you can remember 3 months, 3. Coo also has 3 letters in it. Cooing. At 4 months, ha, ha. 4 letters, child will laugh out loud. At 4 months, child would laugh out loud. Child would laugh out loud. At 6 months, monosyllabic babbling. At 6 months, you will have what is called as monosyllabic babbling. What is monosyllabic babbling? Ma, ba, da. Ma, ba, da. That is monosyllabic. At 9 months, this will turn into mama, baba, dada. That is bisyllabic babbling. This will become mama, baba, dada. That is bisyllabic babbling. Then finally at 1 year, finally at 12 months, that is 1 year, child will say one word with meaning. 1 year, one word with meaning. 1 year, one word with meaning. Some places write it as 1 to 2 words with meaning, but remember 1 year, one word with meaning. At 15 months, child will have what is called as jargon speech. Child will have what is called as jargon speech. Jargon speech is basically child will say words which don't have any meaning. You know, a lot of times children say boo boo for water. They don't have any meaning. Random words which don't have their meaning or some meaning which is known to the child itself. That is what is called as jargon speech. And actual vocabulary will be 15 has 5 in it. Actual vocabulary will be 5 words. Actual vocabulary will be 5 words. Written as 4 to 6 words. Actual vocabulary will be 5 words. And 18 months, picture naming will start. And at 18 months, the vocabulary will be 8. 18 has 8 in it. 8 words. It will be 8 to 10 words. Then at 2 years, 24 months, that is at 2 years, child will say simple sentences with 2 words. 2 word sentences. Child will say what are these 2 word sentences? Tum jao, main aaya, he goes, you come, I go. Sentences like he goes, I come, something. They are proper meaning sentences but 2 word sentences. What is this he? He is a pronoun. He is a pronoun. Instead of saying Aditya goes, you are using he. Aditya is a proper noun. He is a pronoun. So child will start to use pronouns also at 2 years of age. So use of pronouns also starts. Use of pronouns also starts. Vocabulary is around 50 to 100 words. Vocabulary is around 50 to 100 words. At 3 years, child can say 3 things about himself. 3 things. What are these 3 things? His name, age, gender. I'm Aditya, I'm 3 years old, I'm a male boy, I'm a boy. This thing can be said by a 3-year-old child. His own name, his own age and gender. At the same point of time, child will start to use 3-word sentences. Child will start to use 3-word sentences. At 4 years, 4 has 4 in it. Poem also has 4 letters in it. Poem also has 4 letters in it. Child will start to tell a poem. Remember in the childhood, early childhood, you used to go to the, whenever there was a neighbor who used to come and parents used to say, chalo twinkle twinkle little stars now, like that. That poem telling will start here. Storytelling will start here. So poem and storytelling will start here. Along with that, child will start to use what is called as past tense. Child will start to use past tense. So past also has 4 letters in it. So past tense will also start. At 5 years, this past tense will become future tense. Child will start to use future tense. And child will ask meanings of words. Child asks meaning of words. Child will ask meaning of words. Apart from this, there are 3 other small milestones which you should remember because simple one-liners can be asked. First is handedness. Handedness is basically your dominant hand. In the initial time point, initial 1-2 years, you don't have a dominant hand. Child are bidextrous. Okay, they can use either of the hands, right? But this handedness, that whether you're a righty or whether you're a lefty, will start at 3 years of age. This handedness is established by 3 years of age. Now, obviously, at 3 years, when you have established that you are a righty and a lefty, then you can tell, okay, this is the right side, this is the left side. If someone asks you and tell you, go to the right side or go to the left side, this will only develop after an innate sense of handedness, that this is my right hand, this is my left hand, I'm a righty. When this has developed at 3 years, at 4 years, a child will be able to do right-left differentiation, that this is the right side, this is the left side. So, right-left differentiation starts at 4 years of age. And finally, binocular vision. What is the function of binocular vision? Depth perception. This depth perception, binocular vision, will start at 4 months of age. It will start at 4 months of age. It will start at 4 months of age. Start at 4 months of age. The reason we have spent 30 minutes on milestones is the fact that out of all topics, if I'm 100% sure that one question will come from one topic, it is milestones. The one shot and the topics that we are covering in the one shot have been made in such a manner they are the most important topics. There are 2 ways I can go about. Okay, there are 2 ways I can cover the syllabus. I cover everything superficially, or I cover some topics in deep. The one shot has been made in the second manner. It has been made in the second manner. The reason for that is that the same kind of topics keep on getting repeated again and again. What's the point of teaching superficially the most important milestones when there is almost 100% certainty that one question on milestone will come? So this 30 minutes ensures one question is going to come. Rather than in 30 minutes me teaching 10 topics, questions do come from those 10 topics, but you're not able to solve them. Because I taught them superficially only. So there is always 2 ways of revising or 2 ways of going about these, small sessions of these 4 and 5 hour sessions. I can cover one important topics in depth. or I can cover entirety in very superficialness. I'm taking the second approach. All right, that's why if someone has a problem with that, obviously you can always, there is always two ways to go about it. You have to understand that. Okay. Now coming to Down syndrome. Now coming to genetics. Now we'll come to genetics. Now we'll come to genetics, in which we'll discuss about Down syndrome. We shall discuss about Down syndrome. Now, as far as Down syndrome is concerned, what are the features that you will see as far as Down syndrome are concerned? So, simple features. You will see an epicanthal fold here. Here, you will see what? You will see an epicanthal fold. You will see a epicanthal fold. You see epicanthal fold of skin here. The second thing that you will see, that normally what has happened, this is the palpebral fissure. This is normally transverse. Here there will be an upward slant. There will be an upward slant of palpebral fissure. There will be an upward slant of palpebral fissure. The third thing that you will see is the low set ears. You will see low set ears. What do I mean by low set ears? See, normally my ear is in the same line as the ear, as the eyeball. Ears will be low set. They will be below the eyeballs. They will be below the orbit. So here the entire ear is below the orbit. This is below the orbit. There will be low set ear. There will be a flat facial profile and an absent nasal bone. Because there is no nasal bone, the facial profile is flat. They will have single transverse crease. They will have what? They will have single transverse crease. So everyone look at your hand. Everyone look at your hand. You will have two transverse creases. Here you will have a single transverse crease. You will have a single transverse crease. And then coming lastly to the tone, tone will be decreased. They will have what is called as, they will have hypotonia. And whenever anyone has hypotonia, remember this is valid as far as congenital hypothyroidism also is concerned. Whenever there is hypotonia, what's going to happen? The tone here is going to get decreased, so the tongue will come out. There will be protruding tongue. There will be protruding tongue. The second thing that you can do, what will happen because of hypotonia is the tone of the abdominal muscles will not be there. So umbilical hernia will occur. There will be what? There will be umbilical hernia. Now, Down syndrome is associated with certain systemic association. As far as cardiovascular system is concerned, remember the most common congenital heart defect is atrioventricular septal defect, AVSD, or endocardial cushion defect. As far as gut is concerned, in GIT, what's most common? They tend to have duodenal atresia. They will have duodenal atresia followed by annular pancreas. There will also be an increased risk of having celiac and Hertzsprung. Hematologically, they will have ALL, which is more common than AML. This is a very common misconception a lot of people have. This misconception that AML is more common as compared to ALL. No, ALL is actually more common. It's a 6:4 ratio. But in AML, your AML M7, that is acute megakaryoblast leukemia, is most common. AML M7, that is acute megakaryoblast leukemia, is most common. They also have something called as TAM, transient abnormal myelopoiesis. TAM. It is nothing but at birth they will have very high WBC. At birth they will have very high WBC count. They will have a very high WBC count. It occurs because of GATA1 mutations. And in endocrine, they will end up having congenital hypothyroidism. In endocrine, they will end up having congenital hypothyroidism. Now, as far as Down syndrome is concerned, we all know Down syndrome occurs because of, I did not write it down, hopefully everyone knows, there is what? It is trisomy 21. It is trisomy 21. Now, this Down syndrome, the risk of this Down syndrome is directly proportional to maternal age. It is directly proportional to what? It is directly proportional to maternal age. Particularly beyond 35-40 years, the risk increases very rapidly. What is the reason for that? The reason for that is that 95% cases of Down syndrome actually occur because of non-disjunction. They occur because of non-disjunction of maternal chromosome during meiosis. They occur because of non-disjunction of maternal chromosome during meiosis. Now, we know that with increasing age, with increasing maternal age, the risk of Down syndrome will keep on increasing. So a mother, particularly in age group more than 35-40 years, you need to screen for Down syndrome. You need to know whether the child that the mother is carrying, especially above the age of 35-40, whether that child has Down syndrome or not. And in case the child has Down syndrome, mother can then take the decision whether to terminate the pregnancy or not. How do you do the screening? For screening, you can use serum markers or radiographic features. You can use serum markers or you can use radiographic features by doing an ultrasound. So what are the common radiographic features in Down syndrome? There will be increased nuchal translucency or increased nuchal thickness. What is increased nuchal thickness? Here, the neck, the skin at the neck and the fat at the neck will be increased. It will be, this is used in second trimester, this is used in first trimester. Nuchal thickness becomes more than 3 mm. Then there will either be an absent femur or absent humerus and absent nasal bone, which I already told you. They can also have echogenic foci in the heart. Why echogenic foci in the heart? Basically because of that atrioventricular septal defect or endocardial cushion defect. Other thing that they can have apart from this is decreased umbilical blood flow. Decreased umbilical blood flow. So these are the radiographic parameters that you can use to detect Down syndrome in pregnancy. Then in the first trimester, as far as first trimester is concerned, in the serum markers, you can do what is called as dual test, dual test means two things. You can use beta HCG, which will be increased, and pregnancy associated plasma protein A, which will be decreased. PAPPA, which will be decreased. In the second trimester, you can do triple test. Triple test means three things. What are the three things? Beta HCG, unconjugated estriol, and alpha fetoprotein. These are the three things that you will use. Beta HCG will be increased, unconjugated estriol will be decreased, alpha fetoprotein will also be decreased. All these three things, the UE3 and alpha fetoprotein will be decreased. Along with triple test, if you add inhibin to triple test, it becomes what? It becomes quadruple test. Inhibin is increased. How to remember this? High is high. HCG and inhibin. These are the only two things which are high. Only HCG and inhibin is high. Rest everything is low. If you combine the radiological with the dual test, if you combine these radiographic parameters with the dual test, it is called combined test, done in the first trimester. If you use combined test along with triple test, then that is called integrated test. If you use the combined test along with triple test or quadruple test, then it is called integrated test, done in the second trimester. But always remember, all these are what? All these tests that I talked, they are screening tests. Confirmatory test will always be will always be karyotyping. Will always be karyotyping using fetal tissue. That fetal tissue can be obtained using amniocentesis, chordocentesis, or chorionic villus sampling. That is depending upon the time period. We know in first trimester you do chorionic villus sampling, in second trimester you do amniocentesis and chordocentesis. But confirmatory will always be what? Confirmatory will always be karyotyping. It will always be karyotyping using fetal tissue. Then we come to Edward versus Patau. Then we come to Edward and Patau syndrome. Now, Edward and Patau, we all know Edward occurs because E for Edward, E for 18. It occurs because of trisomy 18. P for Patau, P for puberty. Puberty comes at 13 years. Patau is trisomy 13. Patau is trisomy 13. Now, as far as Edward and Patau is concerned, the simple way you can remember the differences between Edward and Patau is per se Patau. Repeat after me. I think a lot of you would already know this. Per se Patau. क्या बोले हम लोग? फिर से मैं बोल रहा हूं एक बार फिर से, so that you always remember. Per se Patau. Per se Patau. Any feature which has per in it will be there in Patau. The feature which does not have per in it will be there in Edwards. Per se Patau. The first thing is rocker bottom feet. Rocker bottom feet. There is no per sound in it. Not there in Patau. It is there in Edward. Cleft palate. Per. Cleft palate is there in Patau. Not there in Edward. Holo prosencephaly. Holo prosencephaly. Per sound. Patau. Not there in Edward. Fingers. Fingers are what? Fingers are per se Patau. Polydactyly in Patau. Polydactyly in Patau. As far as Edward is concerned, Edward will have overlapping fingers. Edward will have overlapping fingers. Kidney. Per se Patau. Patau में क्या होगा? Patau, what will Patau have? Patau will have polycystic kidney. Patau will have polycystic kidney. Edward will have horseshoe kidney. Horseshoe kidney. No per sound. Horseshoe kidney. Edward will have horseshoe kidney. Then cutis aplasia. Cutis aplasia. Per sound will be there in Patau. Not there in Edward. Not there in Edward. What is this holoprosencephaly? It is when the cerebral hemispheres don't separate out. So if the cerebral hemispheres don't separate out, eyes will also not separate out. You'll end up having a single eye. Like a cyclops. Like the cyclops monster. So this is the important difference between Edward and Patau. Per se Patau. Per se Patau. Let's see how it looks as far as pictures are concerned. Let's see this picture. This is what? This is Edward syndrome. 1, 2, 3, 4, 5. This is not polydactyly. These are overlapping fingers. These are overlapping. So this will be seen in Edward. This will be seen in Edward. Let's see this. This is what? These are your rocker bottom feet. Like a rocking chair. Like the rocking chair. So this is rocker bottom feet. Rocker bottom feet. No per sound. Edward. And let's look at here. Can you see the cleft palate? Can you see the eyes are not separated out? Can you see the eyes are not separated out? They're kind of combined together. So this is what? This is Patau. Cleft palate, holoprosencephaly, Patau. So this is a simple way you can differentiate between Edward and Patau syndrome. This is a simple way you can differentiate between Edward and Patau syndrome. Okay. Then we come to Turner and Noonan. Then we come to Turner and Noonan. Now, as far as Turner and Noonan is concerned, you should remember that Turner and Noonan will have same phenotype. Phenotype means physical appearance. Phenotype means physical appearance. So there are two different syndromes, Turner syndrome and Noonan syndrome, which have exactly the same physical appearance. They will have exact same physical appearance. What is this physical appearance? This is how either a child with Noonan or with Turner is going to look like. They will have this webbed neck. They will have this widely spaced nipples. They will have short stature. They will have short stature, and they also have what is called as wide carrying angle. They also have what is called as wide carrying angle. So I like to call this phenotype as 3 Ws for plus short stature. I like to call this phenotype as 3 Ws plus short stature. This phenotype is same in both Turner and Noonan. Both will look exactly, physically they will look exactly the same. What is the physical appearance? The webbed neck, the widely spaced nipple. What is webbed neck? There is an extra fold of skin here. That is the webbed neck. Widely spaced nipple and wide carrying angle. These three things will exactly be the same in case of both Turner and Noonan. Short stature will be same in both Turner and Noonan. Then where is the difference? The difference is in genotype. Remember, Turner occurs because of XO, monosomy X. While Noonan is an autosomal dominant disorder. It's an autosomal dominant disorder that occurs because of PTPN11 mutation, which is a type of RAS gene. Since it is autosomal dominant, because Noonan is autosomal dominant, it can be seen in both males and females. That's why if a male child comes to you with widely spaced nipples, wide webbed neck, wide carrying angle, that is a Noonan syndrome child. Apart from this, there are also certain other minor differences. Most important differences lies in the cardiovascular system defects. Noonan will have right-sided defects while Turner will have left-sided defects. In Turner, the most common congenital heart defect is bicuspid aortic valve. Followed by coarctation of aorta. That is left-sided. Aorta rises from left ventricle. Both the defects are in aorta, either bicuspid aortic valve or coarctation of aorta. Noonan will have right-sided defect. Right means right ventricle. Right ventricle means pulmonary artery. It will have pulmonary stenosis. IQ is normal in Turner. Very important. Turner does not have decreased IQ. Turner has normal IQ. In fact, one Turner syndrome girl has even gotten Nobel Prize. I don't remember the name, but the importance being that IQ is normal in Turner, while IQ is slightly decreased in Noonan. We all know Turner has streak gonads and they will be infertile. There are streak gonads and infertility. As far as Turner is concerned, while fertility is present as far as Noonan is concerned. But remember, fertility is not normal, it is subfertility. And males with Noonan will have cryptorchidism. Undescended testes. Males with Noonan can have cryptorchidism. So this is the differences between, these are some important differences between Turner and Noonan. One very important syndrome as far as your INI-CET is concerned, this is specifically INI-CET loves to ask question on this, is Digeorge syndrome. Now Digeorge syndrome occurs because there is a chromosome 22q11 deletion. There is chromosome 22q11 deletion. Okay. Now, this deletion is in a very small part of chromosome. That's why the syndrome is called microdeletion syndrome, because it cannot be detected by karyotyping. It's a microdeletion syndrome. It's a microdeletion syndrome. Now, what happens in Dijk's syndrome? Because of this 22q11 deletion, there is defective formation of third and fourth pharyngeal arch and its related structure. There is defective formation of third and fourth pharyngeal arch and its structures. Remember, the third and fourth pharyngeal arch is responsible for formation of thymus and parathyroid gland. These are the two most important structures that third and fourth pharyngeal arch forms. So what happens in Dijk's syndrome? Because of this 22q11 deletion, this third and fourth pharyngeal arch won't be formed. So there won't be any thymus and there won't be any parathyroid gland. This results in a characteristic set of manifestation called as Catch-22 syndrome. Now, what does this Catch-22 syndrome stand for? All these things will be seen as far as Dijk's syndrome is concerned. Third and fourth pharyngeal arch is involved. They are involved in formation of your cardiac structure. So they are going to be cardiac anomalies. They will be cardiac anomalies. Most common is conotruncal defects like tetralogy of Fallot. Tetralogy of Fallot is a conotruncal defect. So cardiac defects will be the most common. The next thing that will be abnormal facies. Face structure will be abnormal. That will also result sometimes in cleft palate and cleft lip. That is the second part. There will be cleft lip and palate. The T stands for thymic aplasia. The T stands for thymic aplasia. Thymus is not formed. If thymus is not formed, there will be loss of cell-mediated immunity. You will have recurrent infections. There will be loss of no thymus, no T lymphocytes. No thymus, no T lymphocytes. There will be fall in the number of T lymphocytes. So CBC will show lymphopenia. There will be loss of cell-mediated immunity. They will have recurrent infection, recurrent LRTI, recurrent diarrhea, recurrent gut infection, recurrent sinopulmonary infections, like that. Loss of cell-mediated immunity. And H stands for hypocalcemia. Decreased calcium. Why? Because there is no parathyroid. There is no parathyroid, calcium levels will go down. And this will cause what? This will cause seizures. This will cause what? This will cause seizures. This will cause tetany. This will cause seizures and tetany. So this is why the syndrome is also called Catch-22 syndrome. The 22 parts obviously refers to the 22q11 deletion. It refers to the 22q11. It refers to the 22q11 deletion. It refers to the 22q11 deletion. Next, we come to some important congenital infections, specifically important as far as INI-CET is concerned. First is congenital toxoplasmosis. Congenital toxoplasmosis is characterized by a triad of chorioretinitis, calcifications. Remember, these calcifications are diffuse calcification. They are diffuse calcifications. Calcification in the brain. And hydrocephalus. Then you have congenital rubella syndrome. Congenital rubella syndrome is characterized by a triad of patent ductus arteriosus, sensory neural hearing loss, and cataract. Patent ductus arteriosus, sensory neural hearing loss, and cataract. Very important. They love asking about this patent ductus arteriosus. INI-CET specifically. Which heart defect is most common in congenital rubella syndrome? Answer: patent ductus arteriosus. Very commonly asked fact. After patent ductus arteriosus, the second most common heart defect is VSD here. It is VSD. But most common, they love to ask this most common, patent ductus arteriosus. Patent ductus arteriosus. Then you have congenital CMV infection. This is the most important infection as far as INI-CET is concerned. Every alternate exam, they ask a question on this. So congenital CMV infection is characterized by CMV. CMV. Chorioretinitis, microcephaly, and periventricular calcifications. Chorioretinitis, microcephaly, and periventricular calcification. This is very important. They love to ask this difference. CMV has periventricular calcifications in the brain. Toxoplasmosis has diffuse calcification. This difference they love to ask. Remember, 90% cases of congenital CMV are actually asymptomatic. But all these asymptomatic cases later will end up having sensory neural hearing loss. That's why it is the most common cause of non-syndromic SNHL. Because these children at birth will not have the syndrome. They will not have the striad. They will be asymptomatic at birth. But later in life, they will end up having sensory neural hearing loss. And this particular fact has been asked INI-CT multiple times. CMV is the most common cause of non-syndromic SNHL in children. The method of detection is also important. It is urine CMV PCR. Method of detection is urine CMV PCR. This is the most common. This is the one which is used in less than 3 weeks. Beyond 3 weeks of birth, after 3 weeks of birth, you use blood CMV PCR. Use blood CMV PCR. Then you have treatment. Treatment is Ganji-Cyclovir. Treatment is Ganji-Cyclovir. Then you can have congenital syphilis as well. Congenital syphilis is characterized by a triad of, very important, बुरा ना देखो, बुरा ना सुनो, बुरा ना बोलो. बुरा ना देखो, बुरा ना सुनो, बुरा ना बोलो. बुरा ना देखो, interstitial keratitis. बुरा ना सुनो, 8th cranial nerve palsy. बुरा ना बोलो, Hutchinson teeth. Last is your congenital varicella. Congenital varicella is typically characterized by cicatricial lesions and limb defects. Cicatricial lesions plus limb defects. So if they ever give you limb defects, think congenital varicella. If they ever give you limb defects, think congenital varicella. So this is as far as some important congenital infections are concerned. Remember, all congenital infection, all the torch group of infections that you know about, all the toxoplasma, rubella, CMV, herpes, everything, all torch group of infection can cause massive, if they go and involve the liver and spleen, they can cause massive hepatosplenomegaly. They can cause bone marrow suppression, which can result in thrombocytopenia, which can result in a blueberry muffin rash. That's why I have not taught about that. Blueberry muffin rash, hepatosplenomegaly is something which can occur in all congenital infection. Always remember that the blueberry muffin rash can occur in all congenital infection. It is nothing but a consequence of thrombocytopenia because of bone marrow suppression. So that blueberry muffin rash, hepatosplenomegaly is something which can occur in all congenital infection. What I've taught you is the characteristic feature of each congenital infection. What I've taught you is the characteristic feature of each congenital infection. Now we come to neonatology. Now we come to the second most important part of pediatrics, that is neonatology. We'll first start with important causes of respiratory distress as far as newborns are concerned. We'll first start with important causes of respiratory distress as far as newborns are concerned. The first important cause of respiratory distress in a newborn is respiratory distress syndrome, typically seen in preterm infants. Less than 34 weeks. Why does that occur? Because of lack of maturation of lungs. Lungs are not mature. They have not formed any surfactant. There is a quantitative deficiency of surfactant. And if there is a deficiency of surfactant, what will happen? There will be alveolar collapse. Alveoli will have high surface tension. Surfactant reduces surface tension. Alveoli will have high surface tension. Alveoli will collapse. There will be alveolar collapse. For this respiratory distress syndrome, we use something called as LS ratio. We use something called as LS ratio. This LS ratio stands for lecithin to sphingomyelin ratio. If this LS ratio is less than 2, it denotes a very high risk of having RDS. Remember that lecithin is the main component. It is the main component of surfactant. So if the LS ratio is low, it means there is less lecithin. If the lecithin is less, surfactant is less, high risk of having respiratory distress syndrome. High risk of having respiratory distress syndrome. High risk of having respiratory distress syndrome. Now, coming to the X-ray finding, what will happen? In respiratory distress syndrome, very important. I told you there is lack of surfactant. If there is lack of surfactant, what will happen? In the periphery, the alveoli are there. The alveoli, they won't have any surfactant. They will collapse. They will start to collapse. So if I make a diagram of lungs like this, in the periphery, the alveoli are there. They will completely collapse. They will what? They will completely collapse. So in the periphery, there is going to be what? There is going to be a whiteout. There is going to be a whiteout. There is going to be a whiteout in periphery. Okay? Because of the alveolar collapse. But remember, it's the only the alveoli which have collapsed. Inside the big bronchus will still have air. They won't collapse. They don't require surfactant. They can stay patent. So they will see blackness in a white shadow. This blackness of the bronchus is called air bronchograms. This is what is referred to as air bronchograms. This is what is referred to as air bronchograms. Let me show you the X-ray ones. This is how the X-ray is going to look like. Now very clearly you cannot make out anything. In the periphery, can you see that it's completely white? It's a whiteout. In the periphery there is a whiteout. But if you now look closely here, you would be able to appreciate this is the trachea. This is black. And then this trachea is giving rise to the two bronchus. This blackness that you appreciate on the background of complete white, this is what is called as air bronchograms. This is nothing but your air. This is nothing but your air bronchograms. Coming to the treatment of respiratory distress syndrome, you can either prevent it or you can treat it. If you want to prevent it, you are going to use steroids. We know steroids improve lung maturity. So for treatment, you use antenatal steroids. Which antenatal steroid can you use? Either dexamethasone or betamethasone. Either dexamethasone or dexamethasone. Now, as far as this betamethasone is concerned, what's the dose of betamethasone? Tell me, what is the dose of betamethasone? What is the dose of betamethasone? Tell me. What is the dose of betamethasone? Exactly. ब से 12. 12. Dose of betamethasone is 12 mg. Two doses, 24 hours apart. Dose of betamethasone is 12. ब से 12, 12 mg, two doses, 24 hours apart. Dexamethasone dose is 6 mg, 4 doses. So that the total dose is 24 mg in both the scenarios, given 12 hourly. So this is what you can use for prevention. As far as treatment is concerned, for treatment, the problem is the alveoli have collapsed. Pressure outside is more, inside is less. Inside give pressure, the alveoli won't collapse, they will stay open. What is this called? This is called continuous positive airway pressure. So for treatment, we can use CPAP. Let's say the CPAP also fails. Then the problem is what? There is no surfactant. Give surfactant. The method by which we give surfactant is called Ensure. The method by which we give surfactant is called Ensure. This is intubate, surfactant, extubate. Intubate, surfactant, and extubate. Intubate, surfactant, extubate. Intubate, surfactant, extubate. Ensure. The next we come to apnea of prematurity. Apnea of prematurity again is seen only in children less than 34 weeks. Premature infants. Why does it occur? Basically, when you are born premature, your peripheral and central chemoreceptors are not functioning well. Normally what happens? I take a breath, I take a deep breath out, then again take a deep breath in. There's a small pause between taking the next breath. In these infants, this pause becomes very big. There is a cessation of breathing for more than 20 seconds. So how is apnea defined? If there is a cessation of breathing for more than 20 seconds. If there is a cessation of breathing for more than 20 seconds, that's called apnea of prematurity. Why does it occur? Like I told you, there is immaturity of central and peripheral chemoreceptors. There is immaturity of central and peripheral chemoreceptors. Normally, when we stop breathing, what happens? The carbon dioxide keeps on rising. This high carbon dioxide stimulates these receptors to initiate breathing. Here, these receptors are immature. They won't initiate breathing. They will forget to breathe. Essentially, apnea of prematurity is the CO2 keeps on rising. The infant forgets to breathe. Essentially, has dozed off. Essentially, has snoozed off. So, what will be the treatment? What will be the treatment? The drug of choice, remember, is this caffeine citrate. You will wake up the infant. The drug of choice is caffeine citrate. What is the mechanism of action? What is the mechanism of action? Remember, it is an adenosine antagonist. It is a adenosine antagonist. That is the mechanism of action. Caffeine citrate. You wake up the child. X-ray. Would anything be problematic in X-ray? No. X-ray will be normal. The problem is in the receptors. So X-ray is going to be normal. X-ray will be completely normal in apnea prematurity. Then we come to TTNB, transient tachypnea of newborn. Now this TTNB is seen in term babies, infant of diabetic mother, and specifically seen after LSCS. After LSCS. So what happens normally is that when a baby is born via normal vaginal delivery, the vaginal delivery, it's a violent process. Let's put it this way. Anyone who has seen a delivery even knows that a normal vaginal delivery is a very violent process. It's a very high sympathetic process. So when a baby is born via high sympathetic process, that high sympathetic discharge, high ADRI and ORADRI, it goes to the lungs. In the lung, there is a channel called ENaC channel, sodium channel. It activates those channels. What happens because of the activation of those channels? When a baby is born, these ENaC channels are activated. They'll reabsorb all the fluid which is there in lungs. When you're born via LSCS, this violent process doesn't take place. The sympathetic discharge doesn't take place. That ENaC channel activation doesn't take place. So when a baby is born, that fluid is retained in the lungs. And the retention of that lung fluid results in tachypnea. So why does tachypnea of newborn, transient tachypnea of newborn occur? It occurs because of lack of sympathetic activation of ENaC channel, which results in retention of lung fluid. Remember, it's a disease of term babies only. What will X-ray show? Retention of lung fluids means what? X-ray will be like pulmonary edema. Characteristically, there is a fluid in horizontal fissure. Characteristically, there is fluid in horizontal fissure. Let's look at the fluid. So this is how the X-ray or TTNB looks like. This white line that you see is nothing but fluid which is retained in the horizontal fissure. This is fluid in the horizontal fissure. And you can see that the costophrenic angles, they are also white. It's showing fluid is there in the costophrenic angles at the dependent parts like pulmonary edema. So this is how the characteristic, the X-ray of TTNB is going to look like. How TTNB X-ray is going to look like. There will be fluid in horizontal fissure. Treatment. Name itself tells you everything. It is transient in nature. It will self-resolve in 72 hours. Management is just supportive. Child requires oxygen, give oxygen. That's it. Supportive care. Last is your meconium aspiration syndrome. As far as meconium aspiration syndrome is concerned, it is seen in post-term infants. And the baby basically, post-term means beyond 42 weeks. Beyond 42 weeks period of gestation. What happens? Baby has essentially passed the meconium in utero itself. And then baby has aspirated that meconium. Now this meconium, remember, contains bile salts. It contains biliverdin. This biliverdin, remember, is the reason why meconium is green in color. Why? What is the reason for green color of meconium? It is your biliverdin. Now what will this biliverdin and bile salts do if they go into the lungs? They are chemicals. They will cause chemical pneumonitis. They will cause chemical pneumonitis. Now bile, this meconium will also be like, it will be particles. These particles can cause complete obstruction of an airway. If there is complete obstruction of airway, there will be atelectasis, there will be collapse. In case there is partial obstruction in our body is very characteristic. Whenever there is partial obstruction in the body, air is able to go inside, but not able to come outside. This results in retention of air. Air keeps on coming inside, not able to go outside. Keep on coming inside, not able to go outside. This will result in hyperinflation. And this hyperinflation over a period of time can even lead to pneumothorax. Air leak and pneumothorax. So what will you see on X-ray? You will see all these three things on X-ray. You will see a pneumonia-like picture, you will see collapse, and you will see hyperinflation. Let's see the X-ray once. So this is how the X-ray of meconium aspiration syndrome is going to look like. You can appreciate a pneumonia kind of like picture. First, you can appreciate that. Not going to go into that. Now let's look here. Let's look at the right lung. The right lung, can you see? Right lung is collapsed. The upper lobe is collapsed. This part is collapsed. While the left lung is hyperinflated. This is hyperinflated. Here there is collapse. So you'll see both. You'll see collapse. You'll see hyperinflation. You'll see a pneumonia-like picture. This is as far as your meconium aspiration syndrome is concerned. Treatment, supportive. Nothing you can do. Slowly body will reabsorb. Treatment is going to be supportive. If the child requires mechanical ventilation, you can use one mode of ventilation called high frequency oscillatory ventilation. You can use one mode of ventilation called HFOV, which is high frequency oscillatory ventilation. Then tell me, what is this X-ray? Then tell me, what is this X-ray? Exactly. So this is what? This is congenital. You can see the bowel loops coming into above. This is what? This is nothing but your congenital diaphragmatic hernia or CDH. Some important facts related to CDH you should remember. Most common site, left posterolateral. Most common type, Bogdalek. How will it present? What are the clinical features? Basically, because of congenital diaphragmatic hernia, the bowel loops have come here. They won't allow the lungs to grow. There will be pulmonary hypoplasia, resulting in respiratory distress at birth. There's going to be pulmonary hypoplasia, causing respiratory distress at birth. Causing respiratory distress at birth. And remember, this pulmonary hypoplasia is the main cause of death. This pulmonary hypoplasia is the main cause of death. And second thing that will happen, all the gut loops have come here. Abdomen will become like this, empty abdomen. This is called scaphoid abdomen. This is called as scaphoid abdomen. So there will be empty abdomen, scaphoid abdomen, and pulmonary hypoplasia resulting in respiratory distress at birth. One very important thing related to CDH which they love to ask is bag and mask. Bag and mask is contraindicated. Why? Why is bag and mask contraindicated? See, when you give bag and mask, some amount of air will go from mouth, it will go into the esophagus, it will go into the gut. So this gut is here, it is not there in the abdomen, it's there in the thorax itself. This gut will further expand because of the air. If it further expands, it further will not allow the lungs to breathe. It will further compress the already compressed lung. That's why bag and mask ventilation is contraindicated in congenital diaphragmatic hernia. It is contraindicated in congenital diaphragmatic hernia. Now, as far as respiratory distress in newborns is concerned, it is scored via, this respiratory distress is scored via two scores, Silverman-Anderson score and Downey score. Whatever respiratory distress that we discussed till now is scored via two scores, Silverman-Anderson, Downey's. Remember, the Silverman-Anderson score is used in preterms and it correlates with mortality. Downey's is used in term. It correlates with morbidity. There are 5 components of Silverman-Anderson score: upper chest retraction, lower chest retraction, xiphoid retractions, nasal flaring, and grunting. Each of them are scored 0, 1, and 2. 5 components, 0, 1, and 2. If you give a score of 2 in everything, the maximum score is 10. The maximum score is 10. The minimum score is, if you give 0 in everything, minimum score will be 0. Minimum score is 0. Now, how do you score this? Let's see. How do you score this? As far as upper chest retraction is concerned, you will give a score of 0 if there is no upper chest retraction. If there is no upper chest retraction, you will give a score of 1. Look here. Imagine this is the upper chest. Imagine this is the abdomen. Okay, normally when we breathe, what's going to happen? Chest moves up, abdomen also moves up. Normally when we breathe, what happens? Chest moves up, abdomen moves up. If there is a pathology in the lung, if there is a problem with respiratory distress, what's going to happen when you breathe? Abdomen will move up, chest may move a little later because of the pathology. There will be a lag. If this lag is there, you'll give a score of 1. If this lag is there, you'll give a score of 1. Now again come here. Imagine a scenario, abdomen has moved up, chest hasn't moved at all, so much pathology. Abdomen is moving down, then the chest moves up. Chest moves down, abdomen moves up. Seesaw movements. If you see seesaw movements, you'll give a score of 2. If you see seesaw movements, you will give a score of 2. So this is how you score the Silverman-Anderson score as far as upper chest retractions are concerned. Lower chest retraction, xiphoid retraction, nasal flaring is very easy. If there is no lower chest retraction, score of 1. If there is mild or minimal lower chest retraction, 1. If there is no lower chest retraction, score of 0. If there is mild or minimal lower chest retraction, score of 1. If there is severe lower chest retraction, score of 2. Xiphoid, again same, 0 if there is no xiphoid retraction, mild or minimal, 1, severe, 2. Nasal flaring, again, what is nasal flaring? It basically denotes there is respiratory distress. Baby is flaring the nasum to increase air uptake. If there is no nasal flaring, again score of 0. If there is mild or minimal nasal flaring, score of 1. If there is severe nasal flaring, score of 2. Grunting. Grunting is a respiratory distress sound. If there is no grunting, score of 0. If this grunting is audible with stethoscope, score of 1. If this grunting is so severe that you can hear it audible without stethoscope, with your ear also, you'll give a score of 2. You'll give a score of 2. Then we come to Downey score. Downey score also has 5 components. Downey scores also has 5 components, each scored 0, 1 and 2. The components of Downey scores are respiratory rate, grunting, retractions, air entry, and cyanosis. Respiratory rate, grunting, retractions, air entry, cyanosis. The normal respiratory rate in a newborn is 40 to 60. So if the respiratory rate is less than or equal to 60, you will give a score of 0. If it is between 60 to 80, you will give a score of 1. If it is more than 80, you will give a score of 2. Grunting, exactly the same. I already told you. If there is no grunting, score of 0. If grunting is audible with steth, score of 1. If grunting is audible with ears also, score of 2. Retractions, again, exactly the same. This time, there is no differentiation into multiple retraction. Single retraction. No retraction, 0. Mild retractions, 1. Severe retractions, 2. Air entry. If the air entry is bilaterally equal and normal, 0. If the air entry bilaterally is decreased, you will give a score of 1. If the air entry bilaterally is decreased, you will give a score of 1. If the air entry bilaterally is absent, you will give a score of 2. Cyanosis. If there is no cyanosis, baby is fully pink, 0. If there is cyanosis on room air, you will give a score of 1. If there is cyanosis even on 40% oxygen, you'll give a score of 2. So that's how you score Silverman-Anderson and Downey score. Another very important score is APGAR. APGAR, remember, is scored at 1 minute and 5 minutes after birth. 1 minute and 5 minutes after birth. There are 5 components of APGAR which can easily be remembered by the mnemonic APGAR itself. Appearance, pulse, grimace, activity, and respiratory efforts. Remember, respiratory rate is not a component of APGAR. Respiratory efforts are. Respiratory rate is a component of Downey's. Respiratory rate is not a component. Respiratory efforts are component of APGAR. APGAR, higher the APGAR, better it is. As far as appearance is concerned, you'll give a score of 0 if the baby is fully cyanosed, fully blue. You'll give a score of 1 if the body is pink, but the extremities are blue. This is called acrocyanosis. This is called as acrocyanosis. We'll give a score of 2. After we complete the scores, we'll give a break. We'll give a score of 2 if the body is fully pink. If the baby is fully pink. Pulse. No pulse. 0. No heart rate. Score of 0. If the heart rate is less than 100, you'll give a score of 1. If the heart rate is more than 100, you'll give a score of 2. Grimace. No grimace. 0. Some grimace. Score of 1. What is grimace? We put a nasal catheter and the child will do like this. If there is some grimace, we'll give a score of 1. If the child does like this and sneezes, you give a score of 2. If the child sneezes, you'll give a score of 2. Activity, if the child is limp, you'll give a score of 0. Limp, no activity. If there is some activity, some flexion, you'll give a score of 1. Fully flexed, good activity or fully flexed, you'll give a score of 2. Respiratory efforts, if there are no respiratory efforts, score of 0. Apneic child, if there is proper apnea or 0 respiratory efforts, 0. If there are poor respiratory efforts or distress, if there is poor respiratory efforts or distress, you will give a score of 1. If there are good respiratory efforts, or baby is crying, you'll give a score of 2. Now we come to neonatal sepsis. Remember, the most common cause of neonatal sepsis in India is Klebsiella. If they ask this in NEET PG, in case they ask this in INI-CET, the answer would actually be Acinetobacter. If they ask this in INI-CET. INI-CET AIIMS NICU protocols very clearly say that Acinetobacter is the most common cause. So they ask in INI-CET AIIMS, they are expecting Acinetobacter. If they ask in NEET PG, then Klebsiella is a better answer. If they ask the most common cause in the world, this is as far as India is concerned. In the world, Group B Streptococcus is the most common. Now, what are the risk factors of sepsis? This neonatal sepsis can be of 2 types. Early onset neonatal sepsis, which occurs at less than 72 hours of life. Late onset neonatal sepsis, which occurs more than 72 hours of life, which occurs after 72 hours of life. The early onset neonatal sepsis means that the baby got the infection from the mother. That's why he's having the infection in the first 2 hours, 3 hours. Let's say baby is born within 1 hour, he's having sepsis. Obviously, he has not gotten it from outside. He has gotten it from the mother itself. Late onset neonatal sepsis means he has gotten it from somewhere else. He's gotten it from outside, he's gotten from all the environment. The early onset neonatal sepsis risk factors all are related to maternal genital tract. All the risk factors of early onset neonatal sepsis are related to maternal genital tract. They include chorioamnionitis. There is an infection of the chorion and amnion. Mother gave it to the baby. Prolonged labor or prolonged rupture of membrane. More than 24 hours. Baby spent more time in genital tract, acquired some infection. Along with that, spontaneous prematurity, birth asphyxia, 3 or more sterile PV examinations, or single unsterile PV examination is a risk factor. Obviously, if you're poking so much, you will introduce infection, right? So, chorioamnionitis, prolonged labor or prolonged rupture of membrane, spontaneous prematurity, asphyxia, birth asphyxia, 3 or more sterile pervaginum, or even a single unsterile pervaginal examination, you are introducing infection to the baby, causing early onset neonatal sepsis. Late onset neonatal sepsis occurs after 72 hours of life. Its risk factors are hygiene related, outside environment related. So poor hygiene, poor cord care, bottle feeding, all these will result in late onset neonatal sepsis. Remember, sepsis, the gold standard for diagnosis of neonatal sepsis will always be blood culture. It will always be what? It will always be blood culture. But the problem with blood culture, it doesn't turn out to be positive. It has poor sensitivity. High specificity. Poor sensitivity, high specificity. We need something which is sensitive also. That is your sepsis screen. It has a very high sensitivity and a very high negative predictive value. Sepsis screen. There are 4 components of sepsis screen. These are your absolute neutrophil count less than 1800 per microliter, CRP more than 1 mg per deciliter, micro ESR more than 15 mm per hour, and IT ratio more than 0.2. These are the 4 components of sepsis screen. Any 2 out of these 4 is positive, you will say sepsis screen is positive. ANC stands for absolute neutrophil count. Basically, in neonatal sepsis, whenever there is sepsis, it will cause bone marrow suppression. That's why the neutrophil counts will fall. ANC becomes less than 1800 microliter. There is going to be inflammation, CRP and ESR will become high, and there is IT ratio becomes more than 2. Whatever neutrophils come out, they are immature. This IT ratio stands for immature to total neutrophil ratio. It stands for immature to total neutrophil ratio. So whatever neutrophils come out in sepsis, they are immature. That's why the IT ratio increases. IT ratio becomes more than 0.2. Coming to treatment, treatment is going to be IV antibiotics, supportive care along with IV antibiotics. Which IV antibiotics? Same, ampicillin plus gentamicin. Ampicillin plus gentamicin. In case the sepsis is causing meningitis, then remember ampicillin and gentamicin cannot cross the blood-brain barrier. You have to use cefotaxime. What is going to be the duration of these IV antibiotic? That depends on what turns out to be positive. If sepsis screen is positive, you will give it for 7 days. If blood culture also turns out to be positive, you will give it for 14 days. In case there is meningitis, you need to give it for 21 days. So this will be the duration of IV antibiotics as far as neonatal sepsis is concerned. Then we come to NEC. NEC is necrotizing enterocolitis. NEC is necrotizing enterocolitis. Remember, NEC occurs only 90% cases. The most important risk factor is prematurity. 90% of the cases occur in preterm or premature infants. And the most common site is terminal ileum. It is terminal ileum. Now, most questions of NEC are related to its staging. Which staging? Bell staging. The name of the staging is modified Bell staging. This Bell staging divides NEC into 3 stages. Stage 1, 2 and 3. Stage 1 is suspect NEC. Why suspect NEC? Because on X-ray you won't see any changes. That's why in both stage 1A and 1B, there will be no X-ray changes. Stage 2 is confirmed NEC, you will have X-ray changes. Stage 3 is what? Stage 3 is surgical NEC. It will require surgical intervention. Coming to the characteristic feature of each stage. In stage 1A, you will have occult blood in stool. You will have occult blood in stool. Stage 1A, suspect NEC, X-ray changes, no X-ray changes. That's why suspect NEC. That's why you're suspecting there are no X-ray changes. That's why you cannot confirm it because X-ray changes are not there. But why are you suspecting? Because there is occult blood in stool. In stage 1B, this occult blood in stool will turn into, occult blood means blood is there, microscopic. In 1B, it will turn into gross blood. There will be gross blood in stool. Coming to stage 2. Stage 2 confirmed NEC. Now X-ray changes will be there. In stage 2A, the characteristic feature is thrombocytopenia. On X-ray, you will see changes. That's why it's confirmed NEC. What X-ray change will you see? You will see pneumatosis intestinalis. In stage 2B, you will see the characteristic triad of NEC. The triad of NEC is thrombocytopenia plus hyponatremia plus metabolic acidosis. This is the triad of NEC which you see in 2B. X-ray wise, you will see portal venous gas. X-ray wise, you will see portal vein gas. Stage 3 is surgical NC. 3A is equivalent to peritonitis. 3B is equal to perforation, that is pneumoperitoneum. 3B is equal to perforation, that is pneumoperitoneum. Peritonitis X-ray, you will see what? You will see a lot of itis, inflammation. Inflammation leads edema. There will be a lot of ascites. And in perforation, whenever there is bowel perforation, you see what? You see air under diaphragm. Till 3A, you can treat it with IV antibiotics. 3B requires surgery. 3B requires surgery. It requires exploratory laparotomy. It requires exploratory laparotomy. This is the management. Prevention, what can prevent it? Steroids. Antenatal steroids can prevent it. And breast milk. Formula feeding is known to increase NEC risk, and breast milk is known to protect against NEC. So antenatal steroids, your dexamethasone, betamethasone, they will not improve lung maturity, they will improve gut maturity as well. They improve lung and gut both maturity. So this is as far as NEC is concerned. Now we come to the most important topic, that is your neonatal resuscitation. How will you do neonatal resuscitation? So I've drawn the entire algorithm for you. Let's go through the algorithm, NRP algorithm. Most of the questions can be solved from the NRP algorithm itself. The neonatal resuscitation, we follow the NRP 2021. Neonatal resuscitation protocol 2021 algorithm. It states, how does it start? It starts even prior to birth. It will start prior to birth itself. You will do three things prior to birth. What will you do? You will do antenatal counseling, basically counsel the mother if there is any risk factor. You will do team briefing. What is team briefing? Basically, if 2 or more people are going, you will do role assignment. Okay, that I'll be receiving the baby, you will be doing the suctioning, you will be doing the positive pressure ventilation, so on and so forth. So this is team briefing. Team briefing is nothing but role assignment. And you'll do equipment check. Obviously, prior to the birth itself, you have to check the equipment if everything is functioning. It shouldn't happen that you want to intubate and the intubation equipment is not there, ET tube is not there, oxygen is not there. All these things have to happen prior to birth. Antenatal counseling, team briefing, and equipment check. Then birth happens. Then finally what happens? Birth happens. When the baby is born, you'll ask 3 birth questions. You'll ask what? 3 birth questions. What are the 3 birth questions? Term, tone, cry. Whether the baby has good tone or not, whether baby is term or not, or whether baby has good cry, breathing or not. If the answer to all 3 is a yes, that the baby is a term baby has good tone and cry, If the answer to all 3 is a yes, then you will do what? Then you will do nothing. This baby does not require resuscitation. You will do routine newborn care. You will do what? You will do routine newborn care. If answer to any one of the 3 is a no, child is not crying, child doesn't have good tone, it's a limp baby, or child is not a term baby, then you will do what? You will do the initial steps of resuscitation. Which you can remember by the mnemonic warm pads. What does warm pad stands for? You will warm the baby. You will take the baby into a radiant warmer. Warm the baby. PA stands for position airway. How will you position the airway? Baby's neck can be too flexed, air won't go. Baby's neck can be too extended, air won't go. So position the airway in slight extension method. Position the airway as slightly extended. D stands for dry. You will dry the baby. It will prevent evaporative losses. H stands for stimulate. S stands for you stimulate the baby. How will you stimulate? Will you slap the baby? Never slap the baby. Stimulation has to be gentle. There will be gentle stimulation. There will be what? There will be gentle stimulation. How will you do gentle stimulation? You'll flick the soles of the baby or flick the earlobes or rub the back. So basically soles, earlobes, that's what you'll do. Either flick the soles or earlobes. Gentle stimulation. Never slap the baby. Never slap the baby. And S also stands for, just one second. Yeah. S also stands for suction. But remember, routine suctioning is not recommended. Suction only if required. Suction only if required. As far as suctioning is concerned, most important thing is you'll always suction mouth prior to nose. M before N. You'll always suction mouth first, then nose. The reason is if you suction nose first and mouth already has secretions, when you suction nose, child will get stimulated and he might aspirate the mouth contents. That's why when you are suctioning, always suction mouth first, always suction mouth first, then nose. So this is the initial steps of resuscitation. You will do the initial steps of resuscitation, warm pads. After initial steps of resuscitation, you will see if the child is apneic, gasping, still not breathing, apneic, gasping, still not breathing, or bradycardic, heart rate is less than 100. If the answer to any of these three questions is a yes, you will start what? You will start positive pressure ventilation. Basically bag and mask ventilation. In case the child is breathing, he's not apneic, he's not gasping, he's breathing. But it is what? A labored breathing. It is what? It is labored breathing, or there is prolonged cyanosis. Again showing there is labored breathing resulting in respiratory distress. This is equivalent to the child having respiratory distress. This is equivalent to child having respiratory distress. So you did the initial steps of resuscitation, child starts to breathe, but the breathing is what? Breathing is labored, still having a lot of cyanosis. This is respiratory distress. In respiratory distress, what will you do? You'll give oxygen, you'll give CPAP, you'll position airway, you'll attach a pulse oximeter. So this is what you will do if the child is having labored breathing or prolonged cyanosis. In case after the initial steps of resuscitation, child is still not breathing, apneic, gasping, or heart rate less than 100, anyone is a yes, you'll do what? You'll start positive pressure ventilation. You'll start the bag and mask. Now, when you do bag and mask, you need to know two things. Whether the saturation is increasing and this heart rate which was less than 100, whether that is increasing or not. So you will attach two things. You'll attach for saturation, you will attach pulse oximeter. For saturation, you will attach pulse oximeter. For monitoring the heart rate, you will attach what? You will attach cardiac monitor. You will attach cardiac monitor. Remember, the positive pressure ventilation, it should begin from birth, it should begin within 1 minute. The timeline for positive pressure ventilation, if you have to start positive pressure ventilation, start it within 1 minute of birth. Now you are doing positive pressure ventilation. If you're doing positive pressure ventilation, if it is working, it is effective. If it is working, that heart rate which was less than 100, this heart rate, this bradycardia which was there, will remove. You will have what? You will have increase in heart rate. So the best indicator of effective ventilation, best indicator of effective PPV is what? Increasing heart rate. Let's say the heart rate is not increasing. Heart rate is less than 100. Then you will do what? It means the PPV that you are giving, it means the ventilation that you are giving is non-effective. It means the PPV that you were giving was non-effective. So you'll do what? You'll do the ventilatory corrective steps. If ventilation was non-effective, do ventilatory corrective steps and make it effective. These ventilatory corrective steps are known by the mnemonic MR-SOPA. They are known by the mnemonic MR-SOPA. Let's see these MR-SOPA. Let's see the MR-SOPA. What are the ventilatory characteristics? You are doing positive pressure ventilation, heart rate is not increasing. Means it is non-effective. Make it effective. How to make it effective? Do the ventilatory corrective steps. The ventilatory corrective steps are known by the mnemonic MR-SOPA. It stands for mask readjustment, mask might be here, readjust it, put it properly on the nose and the mouth. Reposition airway. Again, reposition the airway is what? The same, exactly the same. You'll reposition the airway. Slight extension. Slight extension. It should not be too flexed. It should not be too extended. Suction. Again, suctioning. Whenever you're suctioning, mouth, then nose. M before N. Open the mouth. This is called jaw thrust forward. This is called as jaw thrust forward. P stands for increasing the pressure. You will increase the pressure all the way up to 40 centimeter of water. And A stands for alternate airway. If nothing is working, then intubate. A stands for alternate airway, like LMA or ET tube. Like LMA or ET tube. So you did the ventilatory corrective steps. Let's say you did the ventilatory corrective step. Ideally with this, the heart rate should increase because you are giving effective ventilation. If the heart rate is still not increasing, it is less than 60, then you need to start what? You need to start chest compression. You need to start chest compression. You need to start chest compression. So what is the indication of chest compression? What is the indication of chest compression? 30 seconds of PEEP. If the heart rate is less than 60, despite 30 seconds of effective PPV. So you will do the positive pressure ventilation only for 30 seconds. If the heart rate increases, well and good. If the heart rate decreases, it becomes less than 60. You need to start chest compressions. You need to start chest compression. These chest compression, the preferred method is what? The preferred method is two thumb. Two thumb method. So you can use it like two thumb or two finger. Two thumb is preferred over two finger. Two thumb is preferred over this two finger. And this chest compression has to be coordinated with positive pressure ventilation. The ratio is 3:1. 3 chest compression and 1 positive pressure ventilation. And now when you're giving this positive pressure ventilation, it has to be 100% oxygen. It has to be 100% oxygen. So when you're doing chest compression, coordinate with PPV. Coordinate with PPV in a 3:1 ratio. 3 chest compression, 1 positive pressure ventilation breath, and give 100% oxygen. And give 100% oxygen. Now you'll give chest compressions for how long? You'll give it for 1 minute. You'll give chest compressions for 1 minute. If despite 1 minute of chest compression, heart rate is less than 60, you are compelled to use medications. Which medication? Adrenaline. You're compelled to use medication which is adrenaline. So medication, what is the indication of medication? If the heart rate is less than 60, despite 1 minute of chest compression. If the heart rate is less than 60, despite 1 minute of chest compression, you need to start giving medicines. Which medicine? Adre. What is the strength? 1 in 10,000. What is the strength? 1 in 10,000. What is the dose? If you're giving IV or IO, dose is 0.2 ml per kg. If you're giving intratracheal, the dose is 1 ml per kg. This corresponds to 0.02 mg per kg. This corresponds to 0.1 mg per kg. You can keep on giving this adrenaline every 3 to 5 minutes. If despite this adrenaline heart rate is less than 60, think of pneumothorax. Think of hypovolemia. Think of pneumothorax, think of hypovolemia. So with this, we have completed the entire neonatal resuscitation and the algorithm. Prior to birth itself, you'll start with antenatal counseling, team briefing, and equipment check. At birth, you'll ask 3 questions. Term, tone, cry. Term, tone, cry. Answer to all 3 is a yes. You will do routine newborn care. This child does not require resuscitation. If the answer to anyone is a no, you'll do the initial steps of resuscitation. What are the initial steps of resuscitation? Warm pads. Warm pads. Warm the baby, position airway, dry the baby, stimulate and suction. Suction, always remember M before N, and stimulate, always remember, has to be gentle. You will never slap the baby. Now, if after initial steps of resuscitation, there are two possibilities. Child starts to breathe. He was not crying any early. He starts to breathe. It's a labored breathing. Respiratory distress. Do respiratory distress management. Oxygen, CPAP, pulse ox. Child is still not breathing. Child is apneic gasping or bradycardic, heart rate less than 100. After initial steps, you have to start positive pressure ventilation. You have to start positive pressure ventilation. This positive pressure ventilation should begin within 1 minute. It should begin within 1 minute of birth. You'll do PPV. The best indicator of PPV is increasing heart rate. If the heart rate is still less than 100, it means PPV is not effective. If it is not effective, do what? MR Super, do the ventilatory corrective steps. If despite that 30 seconds of PPV, despite that the heart rate is less than 60, do chest compressions. 3:1 ratio. If despite 1 minute of chest compression, heart rate is still less than 60, give adre. Give adrenaline. If despite adrenaline, heart rate is still less than 60, consider pneumothorax and hypovolemia. Consider pneumothorax and hypovolemia. Consider pneumothorax and hypovolemia. As far as congenital diaphragmatic hernia is concerned, we are told you bag and mask is contraindicated. In that scenario, you will directly intubate. If the child is having CDH for PPV, you will not use bag and mask. For PPV, you will not use bag and mask. You will directly intubate. For PPV, you will not use bag and mask. You will directly intubate. You will directly intubate. Now we come to gut. First, we'll discuss diarrhea and the Eimenschia management of diarrhea. Remember, diarrhea in children, the most common cause is viral causes. And amongst virus, it is the rotavirus which is the most common cause. In fact, this is a very simple question which is asked in the November 2024 INICET. Very simple, direct question. Most common cause of diarrhea in children, the rotavirus. Amongst bacteria, the most common cause is E. coli. In HIV, it is your atypical organisms. Example, Cryptosporidium. Cryptosporidium. As far as the diarrheal management is concerned, remember, the diarrhea doesn't kill. It is the dehydration that occurs because of diarrhea kills. So diarrhea management will focus on dehydration, and second thing it will focus upon is the administration of zinc. Why? Zinc, it decreases the duration of diarrhea. It increases epithelial integrity. It decreases the duration of diarrhea and it increases epithelial integrity. That's why we give zinc. What is the dose of zinc? This dose is also important. If the child is less than 6 months, you will give 10 mg of zinc daily for 2 weeks. If the child is more than 6 months, you will give 20 mg of zinc daily, again for 2 weeks. So this is as far as diarrhea management is concerned. Diarrhea management is focused on dehydration management and administration of zinc. Zinc doses I told you, less than 6 months 10 mg, more than 6 months 20 mg given for 2 weeks. Now coming to the management of this dehydration. According to Eimenschia, when a child comes to you, he's having diarrheal stools, clinically assess him and classify into 3 categories. Classify into no dehydration, some dehydration or severe dehydration. You classify into no, some and severe dehydration. In no dehydration, the approximate fluid loss is less than 50 ml per kg. In some dehydration, approximate fluid loss is 50 to 100 ml per kg. In severe dehydration, the fluid loss is at least equal to or more than 100 ml per kg. Child has come to you, you'll classify, you'll clinically assess the child, see the features and classify him into no, some and severe. In no dehydration, fluid loss is less than 50. In some, it is 50 to 100, and in severe, it is more than 100 ml per kg. Now, how do you classify? Which clinical features will you use? You use 4 clinical features: consciousness, thirst, skin pinch, and eyes. Consciousness, thirst, skin pinch, and eyes. No, some, and severe. Let's understand that. In no dehydrations, consciousness will be normal, child will be active, alert. In some dehydration, child has lost some water. He wants water. If he wants water, he'll be very irritable because he wants water. So in some dehydration, child is irritable. In severe dehydration, body has lost a lot of water. Now child won't be irritable. He'll become lethargic and comatose. Child will become lethargic or comatose. Thirst. In no dehydration, there was not much fluid loss. Thirst will be normal. In some dehydration, child was irritable because he wanted water. He has lost some water. He wants water. He'll drink very eagerly. The thirst is increased. He drinks eagerly. He will drink very eagerly. In severe dehydration, child is lethargic. Will he be able to drink? No. Unable to drink. The thirst would be increased, but he's unable, because he's lethargic and comatose, he's unable to drink. Child is unable to drink. Skin pinch. Skin pinches, you do something like this. And you see how fast the skin goes back. The skin will go back fast if there is a lot of water, if the skin turgor is good. So in no dehydration, skin pinch is normal. In some dehydration, it is delayed. In severe dehydration, it is very delayed. Or it is very slow. Eyes. Normally normal eyes. Some dehydration, they will get sunken. You have sunken eyes. And you have very sunken eyes in severe dehydration. Now, how do you classify? Any 2 out of the 4, if it is there, you'll classify into that category. For example, let's say the child is irritable, drinks eagerly, normal skin pinch, normal eyes. You'll call it some dehydration. Another example, let's say child is lethargic, comatose, unable to drink, skin pinch is delayed, eyes are normal. Again, 2 out of 4 classify as severe dehydration. Any 2 out of the 4 classify into that category, higher category. Any 2 out of the 4 classify into that category. Now coming to the management. We use 3 plans: plan A, plan B, plan C. In plan A, there is no dehydration. So there is no need to rehydrate also. So what do you need to do? You'll just replace whatever fluid loss occurs after that. You'll replace ongoing fluid or stool losses. How will you do that? That every time child has a loose stool, he loses some fluid, you'll just replace that. With each loose stool, give 10 ml per kg of ORS. With every loose stool, give 10 ml per kg ORS. Now this ORS, the ORS which we use nowadays is called reduced osmolality ORS. The one we use nowadays is called reduced osmolality ORS. It has 5 components: sodium, glucose, potassium, chloride and citrate. Sodium is 75 millimole per liter. Glucose is also 75. So there is a 1:1 ratio. This stimulates SGLT1 and helps in sodium absorption. And with sodium, obviously water absorption. Potassium is 20, chloride is 65, and citrate is 10, so that the total osmolality is 245. So in no dehydration, child is not dehydrated. He can get dehydrated. We don't want that. So with every loose stool, you will give ORS. With every loose stool, we'll assume body has lost 10 ml per kg of water. You'll replace that 10 ml per kg with 10 ml per kg of ORS with every loose stool. Simply replace ongoing stool losses. Then we come to plan B. In plan B, there is some dehydration. There is some dehydration. So you need to rehydrate. What was the approximate fluid loss? The approximate fluid loss was between 50 to 100 ml per kg. You'll give exactly in the middle of that. You will rehydrate with what? You will rehydrate with 75 ml per kg of ORS. Will you rehydrate with 75 ml per kg of ORS given over 4 hours. Given over 4 hours. So plan B is 75 ml per kg of ORS given over 4 hours. You will rehydrate and get the child back to normal. And if the child is having some other loose stool, keep on replacing ongoing fluid losses with the same 10 ml per kg of ORS with each loose stool. This ORS in plan B can be given orally if the child is taking orally, or can be given via NG. Then we come to plan C. Plan C, child was lethargic, comatose. He will not be able to drink ORS. You have to use IV fluid. Which is the preferred IV fluid? RL with 5% dextrose, followed by RL, followed by NS. Any one of the three can be used. You have to, because he cannot take orally. He's lethargic, comatose. You have to give IV fluids. How much IV fluids? See, in case of severe dehydration, the minimum fluid loss was 100 ml per kg. So you need to give at least 100 ml per kg of IV fluids. This 100 ml per kg is given in 2 aliquots. It's given in 2 aliquots. First we give a 30 ml per kg, then we give the remaining 70 ml per kg for a total of 100 ml. Per kg. If the child is more than 1 year, the 30 ml per kg is given over half an hour. The remaining 70 ml per kg is given over 2.5 hour. So that the entire 100 ml per kg is given over 0.5 plus 2.5, 3 hours. If the child is less than 1 year old, the 30 ml per kg is given over 1 hour. The remaining 70 ml per kg is given over 5 hours. So that the entire 100 ml per kg is given over 6 hours. This is severe dehydration. Severe dehydration, at least 100 ml per kg is lost. Give 100 ml per kg IV fluids. Why? Child is lethargic, comatose, cannot take orally. Duration, less than 1 year, more than 1 year. More than 1 year, over 3 hours. Less than 1 year, over 6 hours. If I summarize, in no dehydration, what is the fluid? ORS. How much do you give? You give 10 ml per kg with each loose stool. No time point. Whenever there is a loose stool, you give 10 ml per kg. In some dehydration, you give ORS again. You can give NG or oral. Amount is 75 ml per kg. Given over 4 hours. In severe dehydration, now you use IV fluids. RL with 5% dextrose is the preferred one. Amount is at least 100 ml per kg. Given over 3 hours or 6 hours. More than 3 hours, 3 hours if the child is more than 1 year. 6 hours if the child is less than 1 year. This is the management of dehydration. Then we come to maintenance fluid. What is the concept of maintenance fluid? Remember, the concept of maintenance fluid is the fluid which you require on a daily basis. That's why it's also called daily maintenance fluid. This is the fluid which you require on a daily basis. It has nothing to do with dehydration. What is the concept of maintenance fluid? We say on a daily basis you should drink 2 to 3 liters of water, right? That fluid that you drink on a daily basis, that water that you drink on a daily basis to maintain your bodily function, that is the maintenance fluid. It has no relation with dehydration. It is the fluid which you require on a daily basis. What is the ideal maintenance fluid? If someone asks you what is the ideal maintenance fluid, tell me what is the ideal maintenance fluid? What is the ideal maintenance fluid? What would be the ideal maintenance fluid? It is a fluid that you require on a daily basis. What is the ideal maintenance fluid? Tell me, what will be the ideal maintenance fluid? Water! The ideal maintenance fluid is water. It's H2O. If a person is functioning normally, on a daily basis, he needs to drink water. The ideal maintenance fluid is this. पानी की प्यास, जब भी मैंने बोला था ना, पानी की प्यास, पानी ही बुझा सकता है. Maintenance fluid is water. Ideal maintenance fluid is water. Then they ask a question sometimes. Then they sometimes ask a question. If the child is NPO, if the child is NPO, he cannot drink water, then which IV fluid will you give? Then the answer is going to be DNS, that is NS with 5% dextrose. Then the answer is going to be NS with 5% dextrose, not N by 2. N by 2 was considered the ideal maintenance fluid 20 years ago. So if someone is telling you N by 2, they are wrong. They are right 20 years ago. They were right in 2000. They were right till 2005, 2010. What is the current year? Current year is 2025. In the current year, in 2025, the answer is NS with 5% dextrose. The answer is NS with 5% dextrose. Specifically, AIIMS and PGI have done studies. And AIIMS and PGI only, INICET only asked this question. They asked this question because they know they did studies and the answer is NS with 5% dextrose, not N by 2. Remember that. Remember that. Now, this maintenance fluid is calculated with a formula called Holiday-Cigar formula, which says if the baby is between 1 to 10 kg, for the first 10 kg, you calculate the maintenance fluid as 100 ml per kg given in 24 hours. If the baby is between 11 to 20 kg, you calculate it as 50 ml per kg for every kg. Again given over 24 hours. And beyond 20 kg, every kg is calculated as again 20 ml per kg given in 24 hours. Given in 24 hours. Let's understand this with the help of an example. Tell me, what will be the maintenance fluid in a 17 kg child? What will be the maintenance fluid in a 17 kg child? What will be the maintenance fluid in a 17 kg child? What will be the maintenance fluid in a 27 kg child? Let's understand this. Tell me. People who are writing it, write down. Very correct. See, 17 kgs can be written as 10 plus 7. First 10 kgs. First 10 kg is 100 ml per kg. 10 into 100, 1000 ml. Next kg till 20 kg. How much is left? 7 is left. Next 7 kg is 7 into 50. 7 into 50 is equal to 350 ml. So this will become 1350 ml. So the maintenance fluid in a 17 kg child will be 1350 ml in daily maintenance. This in 24 hours. That is the daily maintenance. For 27 kg child, again the same. First 10 kgs, 10 into 100 is equal to 1000. Next 10 kgs till 20 kgs. This is 10 plus 10 plus 7. Next 10 kgs. 10 into 50 is equal to 500 ml. And above that, every kg, the 7 into 20 is equal to 140 ml. So the maintenance fluid will be what? The maintenance fluid will be, one second. The maintenance fluid will be, add it all together. 1000 plus 500 plus 140, it will be 1640 ml. It will be 1640 ml. That will be the maintenance fluid in a 27 kg child. That's how you calculate the maintenance fluid. Okay. Remember, the ideal maintenance fluid if you are taking orally is water. If NPO, then it is DNS. Coming to respiratory system, we'll discuss about pneumonia. The IMNCI management of pneumonia. Now, as far as the IMNCI management of pneumonia is concerned, just like dehydration, a child came to you with dehydration, you classified him into 3 categories. You classified him into no dehydration, some dehydration, and severe dehydration. Here you will classify into no pneumonia, pneumonia, and severe pneumonia, or very severe disease, or very severe disease. No pneumonia, there is no pneumonia, pneumonia is there, severe pneumonia is there. Again, a child comes to you with respiratory distress, you will classify into 3 categories. No pneumonia is when there is no feature of pneumonia or severe pneumonia. No pneumonia obviously means that there is no pneumonia. There is no feature of pneumonia or severe pneumonia. There is only cough and cold. Mild fever can be there. Mild fever or wheezing can be there. But there is no feature which is suggestive of pneumonia or severe pneumonia. There is only cough and cold. Mild fever or wheezing can be there. If there is no pneumonia, there is no feature suggestive of pneumonia. If there is no pneumonia, what is the treatment? Will this child require antibiotics? No. No antibiotics. So what will you do? There is only cough and cold. There is only cough and cold, right? Cough and cold. Vicks ki goli lo, khich khich dur karo. You'll give Vicks. You'll give soothing measures. You'll give Vicks. You'll give what? You'll give soothing measures. You'll give soothing measures. If wheezing is there, you can consider giving salbutamol. That's it. There is no need of any antibiotics. Remember, because there is no pneumonia. If there is no pneumonia, what's the role of antibiotics? No role of antibiotics. No antibiotics. Then you come to pneumonia. Now, pneumonia can be of two types. Fast breathing pneumonia and chest indwelling pneumonia. Fast breathing pneumonia and chest indwelling. So a child comes to you, he's having chest indwelling, automatically becomes pneumonia. A child comes to you, he's having fast breathing. Fast breathing means high respiratory rate, automatically becomes pneumonia. Now this fast breathing will have cutoff. These cutoffs are dependent upon the age of the baby. For less than 2 months, the respiratory rate cutoff is 60. For 2 to 12 months, the respiratory rate cutoff is 50 per minute. And more than 12 months, the respiratory rate cutoff is 40. It is 40. A child comes to you, he's not having fever, he's just having cough cold, but the respiratory rate is above the cutoff. Automatically becomes fast breathing pneumonia. Child comes to you, otherwise completely fine, but you see chest indwelling, automatically becomes chest indwelling pneumonia. Now, if there is pneumonia, you need to give antibiotic. Which antibiotic? Oral amoxicillin. You will give oral amox for 5 days. You will explain the danger signs and ask to follow up after 2 days. You will ask to follow up after 2 days. Pneumonia, antibiotic, oral antibiotic, 5 days. Let's say where there is severe pneumonia. When do you call it a severe pneumonia? You call it a severe pneumonia if there is a stridor in an otherwise calm child. If you hear stridor in an otherwise calm child, or there are features which suggest this very severe disease. What can be these features? 1 second. There is stridor in an otherwise calm child, or there is features which suggest there is very severe disease. Very severe disease means high-grade fever. High-grade fever. Child having lethargy. Fall in SpO2. Or child having seizures or convulsions. All these will denote what? These are danger signs. These will denote child is having a very severe disease. Call it severe pneumonia. In this case, remember IMNCI is made from a PHC point of view. You cannot manage. Refer. Say thank you. Thank you for coming. Now go to a higher center. Treatment will be refer to higher center. Don't be hero. You are in a PHC, refer to higher center. But, obviously there is a but. Give the first dose. Refer to higher center after the first dose of IV antibiotic. Which IV antibiotic? Ampicillin or Genta. Ampicillin or gentamicin. So severe pneumonia or very severe disease cannot be managed in a PHC. Refer after giving the first dose. So this is the IMNCI management of pneumonia. Then we come to the single most important topic in systemic pediatrics after dehydration, probably cystic fibrosis. One question related to cystic fibrosis. Somehow cystic fibrosis was not that important a topic when I was giving my exam 7 or 8 years ago. But nowadays, this is a question, like if you go through past 3-4 papers, every paper has a question on cystic fibrosis. Every paper has a question on cystic fibrosis. So let's see what happens in cystic fibrosis. In cystic fibrosis, remember, there is a defect in a gene called CFTR. There is a defect in a gene called CFTR, which is present on chromosome 7. The most common mutation in this gene is delta F508. Delta F508. Delta F508 stands for deletion of, this delta stands for deletion, this F stands for phenylalanine. At the 508th amino acid position. Delta F508 stands for this. Delta stands for deletion, F is phenylalanine, 508 is the amino acid position. Now, what is the function of the CFTR gene? It's a chloride conductance channel. It's a chloride conductance channel. Now, let's see how does the mutation of the CFTR results in all its manifestation. Let's see it now. Now, the function of CFTR all throughout the body is same except in sweat glands. In sweat gland, the function is opposite. So when I'm saying airways and pancreas, I also mean gut. I also mean other parts of the body as well. So in airways and pancreas, let's understand what the CFTR does. What the CFTR does is, the CFTR, let's say it's here, it will transport chloride from inside the cell into the lumen. It will transport chloride from inside the cell into the lumen. Chloride has come into the lumen. One second, I'm so sorry. Yeah. So the function of CFTR is, it's a chloride conductance channel to transport chloride from the inside the cell into the lumen. Chloride comes into the lumen, it will attract a lot of sodium. It will attract a lot of sodium. Chloride is negative, sodium is positive. Now, if sodium chloride has come into the lumen, it will attract a lot of water. This will attract a lot of water into the lumen. And secretions will become watery. Water in lumen will cause watery secretions. So what will happen in cystic fibrosis? What will happen in cystic fibrosis? Nothing of this sort will happen. This chloride won't come, the sodium won't come, and most importantly, water won't come. If water doesn't come, there won't be watery secretions. You will have thick secretions. You will have thick secretions, and this thick secretions will cause obstruction. This thick secretions will cause obstruction. The thick secretions are there in the lungs. They will cause obstruction. They will cause recurrent infections, recurrent LRTI, which will lead to bronchiectasis. Thick secretions in pancreas. Pancreatic enzymes won't be able to get in the lumen. Pancreatic insufficiency. If pancreas enzymes are not there, fat will not be absorbed. Fat malabsorption. Pancreatic enzymes are not coming into the gut. They stay in the pancreas. Pancreas will get what? Pancreas will end up getting there will be activation of pancreatic enzymes in the pancreas itself, pancreatic inflammation, pancreatitis. Sooner or later, that pancreatitis will destroy entire pancreas. Diabetes mellitus. Gut, in the gut, secretions will become thick. You will be constipated, delayed meconium passage. And there is one obstruction God gives them. They don't have vas deferens. They don't have vas deferens. Congenital absence of vas deferens resulting in obstructive azoospermia. So every manifestation of cystic fibrosis is thick secretion causing obstruction. Because this thick secretion is the core of cystic fibrosis. That's why cystic fibrosis is also called thick mucoviscoidosis. It's also called mucoviscoidosis. It's also called mucoviscoidosis. The only place where the function of this chloride channel is different is sweat glands. In the sweat glands, this CFTR helps in absorption of chloride and absorption of sodium. So what will happen in cystic fibrosis? It won't go inside. This chloride will stay in the lumen and increase, resulting in increased sweat chloride. And this is used for diagnosis. So what are the clinical features? In airway, you will have recurrent LRTI. Which will lead to bronchiectasis. The most common organism is, remember, staph. The most common organism is staph, followed by Pseudomonas. Highest mortality Highest mortality seen with Burkholderia. Highest mortality seen with Burkholderia. There will be exocrine pancreatic. Pancreatic enzymes won't be able to come. They're thick. They're not coming into the gut. This will lead to fat malabsorption. This will lead to fat malabsorption, which is also called steatorrhea. In the intestine, thick secretions will cause obstruction, which is called distal intestinal obstruction syndrome. There will be constipation. You will try to do a lot of pressure. That excess pressure will cause rectal prolapse. And then they have congenital absence of vas deferens. This will lead to obstructive azoospermia. This will lead to obstructive azoospermia. Coming to the diagnosis, how will you make the diagnosis? I told you sweat chloride. If the sweat chloride is more than 60 milliequivalent per liter on 2 or more occasions, then you can make a diagnosis. Or if there is a abnormal nasal potential difference, then you can make a diagnosis. Or there are 2 or more known mutations in CFTR gene. That's how you can make a diagnosis. So diagnosis, you use sweat chloride. If you have high sweat chloride on 2 or more occasions, you can make a diagnosis. If that's not there, you can use abnormal nasal potential difference. If that's not there, detect the mutations, the gene mutations in the CFTR gene, the delta F508 that we talked about. Coming to the treatment, you will do chest physiotherapy, obviously. Because pancreatic enzyme is not there, you will do enzyme replacement. You will do pancreatic enzyme replacement. Chest physiotherapy, what we will do? Chest physiotherapy, you will take out the secretions. This will do what? This will decrease the risk of LRTI. You will do pancreatic enzyme replacement. And then there are newer drugs. 2 caftors. Lumecaftor and ivacaftor. Lume and ivacaftor. Lumecaftor, as far as lumecaftor is concerned, what does lumecaftor do? Lumecaftor is a chaperone protein. Lumecaftor is a chaperone protein. It will stabilize the CFTR protein. Chaperone proteins are stabilizing protein. They stabilize protein. They improve protein folding. So it improves CFTR folding. If the CFTR folding is improved, there will be increased expression of the CFTR protein, resulting in increased expression. Ivacaftor will increase chloride conductance via the CFTR channel. It causes increased chloride conductance. It will cause increased chloride conductance. What do I mean by increased chloride conductance? That let's say the CFTR channel that was there, it was defective. It was supposed to transport 100 chloride ions. It was transporting only 10 chloride ions. If you give ivacaftor, instead of 10, it will now start to transport 20, 30, 40. So it will cause increased chloride conductance via the CFTR. Lumecaftor, it will increase the expression of CFTR. CFTR probably was misfolded. That's why it's not getting expressed. It folds it and causes improved expression. Then coming towards the end of the class, some important chest x-rays as far as congenital heart disease is concerned. Some important chest x-rays as far as congenital heart diseases are concerned. This is what? Snowman appearance. This is figure of 8 or Snowman appearance. This is seen in TAPVC. Alright, total anomalous pulmonary venous connection. Then you have this. This is the characteristic boot-shaped heart or Cor en Sabot. This is seen in where? This is seen in TOF, tetralogy of Fallot. This is seen in tetralogy of Fallot. Then you have this. This is box-shaped heart. This is seen in Epstein anomaly. Remember, Epstein anomaly can occur with lithium intake in mother. Lithium in mother can cause Epstein anomaly.
can cause Epstein anomaly. Another thing seen in Epstein anomaly is Himalayan P waves. There is RA enlargement. This extra part, this box part is nothing but RA. This is nothing but your right atrium. There is RA enlargement in Epstein anomaly that leads to Himalayan P waves. That leads to Himalayan P waves. And finally, you have the Egon string appearance, which is seen where? Which is seen in transposition of great arteries. Which is seen in transposition of great arteries. Now, obviously, there is not enough time. In a one shot, you can never, CHD is probably one of the most tough topics that itself can take 1-2 hours, never going to be covered. I covered the most important chest x-rays. I'll talk a little bit about tetralogy of Fallot. Now, as far as tetralogy of Fallot is concerned, what are the 4 components of tetralogy of Fallot? I want to explain that to you. The 4 components of tetralogy of Fallot are pulmonary stenosis, right ventricular hypertrophy, large VSD, and overriding of aorta. These are the 4 components of tetralogy of Fallot. Let's understand tetralogy of Fallot, why I have written this sequence in this particular manner. Let's understand that. So in tetralogy of Fallot, the main problem, this is RA, this is RV, this is LA, this is LV, this is pulmonary artery, and this is aorta. All right. Now remember, see with me, understand this very important thing. The main problem in tetralogy of Fallot is only one thing. It is the pulmonary stenosis. That is the main problem. As far as tetralogy of Fallot is concerned. Main problem is what? It is your pulmonary stenosis. And what happens because of pulmonary stenosis? The right ventricle wants to pump the blood into the pulmonary artery. The right ventricle wants to pump the blood into the pulmonary artery. It is unable to do so. Wants to contract. In response to this pulmonary stenosis, what happens in right ventricle? It undergoes hypertrophy. So that becomes the second component. This will undergo hypertrophy. There will be right ventricular hypertrophy, the second component of tetralogy of Fallot. Right ventricle really wants to contract. It wants to send the blood into the pulmonary artery. It's not able to do so because there is pulmonary stenosis. Then what happens? There is a huge VSD. Here. So right ventricle, if it's not able to send the blood into pulmonary artery, it starts sending blood to the left ventricle. It starts to send the blood from the right side to the left side into the left ventricle, resulting in a right to left shunt through the VSD. So there is the third component, VSD, through which the right to left shunt occurs. Right deoxygenated blood, left oxygenated blood, deoxygenated blood going to left side, cyanosis. This VSD is a huge VSD. All the blood of right ventricle easily reaches the left ventricle. It doesn't go into pulmonary artery, it goes to the left ventricle, causing mixing, causing cyanosis. Now, when there is such a huge VSD, if I take a sideways picture, let's say there is pulmonary artery, this is right ventricle, this is left ventricle, this is aorta. There is pulmonary stenosis. Now look at this. If there is a huge VSD, the left and right ventricle are a common chamber. And aorta is essentially arising from a common left and right ventricle. Because of this huge VSD, this aorta which arises from a common left and right ventricle is called overriding of aorta. Right ventricle is not able to send the blood into the pulmonary artery. It directly sends blood into left ventricle into the aorta. This is called overriding of aorta. So what is the main problem in tetralogy of Fallot? Pulmonary stenosis. More the pulmonary stenosis, more the right ventricular hypertrophy, more the pulmonary stenosis, more the blood will go from right ventricle to left ventricle, more cyanosis. So cyanosis in pulmonary, cyanosis and tetralogy of Fallot will directly be proportional to this pulmonary stenosis. The main pathophysiology is always this pulmonary stenosis. And because there is a huge VSD, the aorta seems to arise from a common left and right ventricle called overriding of aorta. I hope now you understood why I had written in that particular sequence. The main problem is what? It is pulmonary stenosis. This leads to right ventricle hypertrophy. There is no way for the blood to go from right ventricle into the pulmonary stenosis, into the pulmonary artery. So blood goes via the large VSD. From the large VSD, there is a right to left shunt causing cyanosis. And because there is a huge VSD, that causes overriding of aorta. Can I say that pulmonary stenosis will be directly proportional to cyanosis? Higher the pulmonary stenosis, more the right to left shunt, more the cyanosis. Okay. Why does this boot-shaped heart occur? See, normally the heart is like this. This is RA, this is LA, this is RV, this is LV. In case of tetralogy of Fallot, there is right ventricular hypertrophy. So this right ventricle becomes like this. And it pushes the left ventricle up. That's why there is a boot-shaped heart. This entire part is nothing but the right ventricle hypertrophy that has occurred, which has pushed the LV, up, left ventricle up. This is called upturning of apex. Upturning of left ventricle or apex. So this is as far as tetralogy of Fallot is concerned. 4 components. Stenosis, right ventricle hypertrophy resulting in right to left shunt via the huge VSD. Aorta seems to rise from a common chamber. Overriding of aorta. More the stenosis, more the right to left shunt, more the cyanosis. And that's why the cyanosis will directly be proportional to pulmonary stenosis. So I have to explain to you the tetralogy of Fallot in some simple terms. The second last thing that we'll do, this I won't discuss in too depth because this is actually a physiology and medicine topic. Congenital adrenal hyperplasia. Remember, congenital adrenal hyperplasia, all are autosomal recessive. Remember that. How do you make a diagnosis in congenital adrenal hyperplasia? First, simply look at whether they are giving you in the clinical scenario. This is only for revision. Whether they're in the clinical scenario, they're giving you hypertension or hypotension. If they're giving you hypotension or salt wasting, there is only 2 differential. It can either be 21 hydroxylase deficiency or it can be 3 beta hydroxysteroid dehydrogenase deficiency. In 21 hydroxylase deficiency, there is virilization. In 3 beta, no testosterone is formed, there is no virilization. So if they give you hypotension, salt wasting and virilization, then the answer is 21 hydroxylase deficiency. If they give you hypotension with no history of virilization, then the answer is 3 beta hydroxysteroid dehydrogenase deficiency. If they give you hypertension, high BP, then again look whether there is virilization or not. If virilization is there, then the answer is going to be 11 beta hydroxylase deficiency. If virilization is not there with hypertension, then the answer is going to be 17 hydroxylase deficiency. So this is a very simple flowchart that you can revise on the last day before the exam so that you mark congenital adrenal hyperplasia questions correctly. I won't go into the in-depth detail, that's going to take too much time, not something for one shot. But this simple flowchart, you should revise 1 or 2 days prior to the exam and you'll get the question correct. The last thing that we'll discuss are some important epilepsy syndromes. The first is what is called as Janz syndrome or juvenile myoclonic epilepsy. Typically seen in adolescent females. The characteristic clinical feature is myoclonic epilepsy, myoclonus. It is myoclonic jerks on waking up. They will have what is called as drop attacks. What is drop attacks? Let's say they are holding something in their hand. Suddenly the hand will have a myoclonic jerk. They'll drop it. Drop attacks. What are the triggers for this epilepsy, these myoclonic jerks? The triggers are alcohol and lack of sleep. No sleep. Treatment, drug of choice is valproate. Drug of choice is valproate. Then you have West syndrome. Remember, West syndrome occurs in infancy. It's characterized by a triad of developmental regression, hips arrhythmia on EEG, and infantile salam spells. Infantile salam spells. So these children will have developmental regression, infantile salam spell. What are salam spells? They will have jerks like this. So it's called salam spells. And on EEG, you will see hips arrhythmia. Now, the drug of choice for this is ACTH. But if they ask you an INI-CET, then please choose steroids as the answer. If West syndrome, this West syndrome can be of two types. It can be primary or secondary. Primary means there is no underlying cause. Secondary means secondary to some other defect. If this West syndrome occurs with tubular sclerosis, then the drug of choice is vigabatrin. If you have West syndrome with tubular sclerosis, then the drug of choice is vigabatrin. Then you have something called as SMEI, severe myoclonic epilepsy, or Dravet syndrome. It occurs because there is a defect in SCNA, sodium channel. There is a defect in sodium channel. Onset is in infancy. The characteristic clinical feature here is there is a characteristic way this disease progresses. Initially, there will be febrile seizures, followed by these seizures occurring at lower temperature, followed by afebrile seizures, followed by seizures of multiple types. So febrile seizures at lower temperature triggering febrile seizures, then afebrile seizure, and finally seizures of multiple types. Very characteristic feature of Dravet syndrome. Drug of choice is valproate. And now there is a new drug called stiripentol. Last is your Lennox-Gastaut syndrome. Lennox-Gastaut syndrome typically occurs in 2 to 8 year children. It is characterized by a triad of developmental regression, multiple seizure types which are difficult to control, and 2 to 3 hertz spike wave complex on EEG. Drug of choice is valproate. With this, we have completed the one shot in 5 hours, the stipulated time, 5 hours, 5 minutes. And I'll take your leave now. The few topics from systemic pediatrics which I would ask you to revise probably on your own. Most of the things, general pediatrics mostly, good important topics of neonatology we have actually done. Systemic pediatrics, a good portion actually probably would have been covered in medicine and pathology. That's why I did not go too much in depth in that. The few topics that I might ask you to cover, they're easy topics. That's why I did not cover is your muscular dystrophy, Duchenne muscular dystrophy, and febrile seizures. That's about it. Febrile seizures and Duchenne muscular dystrophy. These are 2-3 more topics which you can consider. Tetralogy of Fallot also have done. Congenital heart disease, most commonly the question which is asked from tetralogy of Fallot, that also the basic concept, most important concept I've already done. So most of the things are actually done. Alright. With this, I take your leave. Thank you. Thanks a lot. I think we are done with the thing. Yeah. Neonatal jaundice, it's an easy topic, I would say. If you really want me to talk about, I can talk. See, there are multiple topics that we can do. Like I said, neonatal jaundice, most commonly the question that they ask is, what will you do? You'll do phototherapy mechanism of action, Lume-Rubin conversion. The easy question. They're not tough questions. They're not conceptual questions. Most important question, very high probability of likelihood asking, cystic fibrosis, milestones, Kwashiorkor marasmus, growth charts, all that thing, growth curves, all that thing I've covered. Okay. You can't cover in 5 hours. You can't cover the entire pediatrics, obviously. But the most important topics I've covered. Thank you. You do PPV in meconium aspiration. Remember, you do PPV in meconium aspiration. It's not contraindicated. In meconium aspiration, PPV is not contraindicated. You will do PPV. You will do PPV. Order of investigation and recurrent UTIs. Hypoglycemia value, I'll tell you once. This is why people get confused. See, hypoglycemia can be of two types. It can occur in SAM and it can occur in neonates. In SAM, the cutoff is less than 54. In neonates, the cutoff is less than 40. Just remember that. Okay, just remember this. In SAM, the cutoff is 54. In neonates, the cutoff is 40. That's why people get confused. That's why people get confused. PPV is not contraindicated. PPV is not contraindicated. Cerebral palsy also, if you want me to talk about cerebral palsy, let me talk about cerebral palsy. Just one thing you need to know about cerebral palsy. This is it. Cerebral palsy occurs because of birth asphyxia. When the baby does not take a breath at birth, right? When the baby's birth asphyxia, baby does not cry at birth, that leads to cerebral palsy. Whenever there is birth asphyxia. Now, birth asphyxia can occur in term and preterms. In term, it leads to parasagittal infarct. In preterms, it leads to periventricular infarct. Parasagittal and periventricular. Parasagittal infarct leads to spastic quadriplegia. All the 4 limbs are affected. Periventricular infarct leads to spastic diplegia. So preterms will have spastic diplegia. Terms will babies will have spastic quadriplegia. Diplegia, which diplegia? Lower limbs. Only the lower limbs are involved. Bilateral lower limbs are involved. That's it. In term babies, to see the prognosis, you need to do an MRI. In preterm babies, you need to do an ultrasound. Ultrasound brain, obviously. That's it. Maximum question of cerebral palsy can be solved from this table. Someone asked about cerebral palsy. Let me do the cerebral palsy as well. Okay. Maximum question of cerebral palsy can be solved from this. Why does cerebral palsy occur? Because you don't take oxygen at birth. So there is infarction, there is asphyxia at the brain. This has different pattern. Term baby has parasagittal infarct leading to spastic quadriplegia. Preterm baby has a periventricular infarct leading to spastic diplegia. 99% of the question can be solved. This periventricular infarct in preterms is also sometimes called periventricular leukomalacia. This is also sometimes called as periventricular leukomalacia. Called as periventricular leukomalacia. That's it. Yes, I will share the annotated PDF. Last 30-day strategy I will tell you. Let me just tell you. See, I will advise you guys one thing. Very simple thing. It's probably going to make a video also this. Although considering war, there is a good possibility exam might get postponed. That's a very good possibility, but please keep on studying. I think if anything possibility, INI-CET might get postponed if there is a possibility, not NEET PG, because Pakistan cannot tolerate one month of war. They'll go bankrupt before that. So INI-CET might get postponed, but NEET PG is not getting postponed. Please keep on, if your goal is NEET PG, please keep on studying. My simple advice to you is in the 7 to 10 days which are left for INI-CET, please revise first and second prof. from one shot, do anatomy a little more in depth, do forensic a little more in depth. INI-CT gets over on 17th, 17, 18, I'm not remembering the exact date. Then you have till 15th June. 2 revisions. 1 revision till 8th of June and then one final revision. This you will have 20 days, 1 subject per day, followed by subject-wise test. And then 2 subject per day in this 1 week. In the last week, there is no need, do it in such a manner in this 20 days that in the last 5 days, you're actually doing surgery and OBGY. In that 20 day, in the last 5 days, you're doing surgery and OBGY. So that the surgery and OBGY continues into the last 7-day revision. And in the last 7-day revision, again do a repeat of this first and second prof revision. You've already done that. You know how to do that. Again, do first and second prof revision. Surgery, OBGY, and have been done in the past 5 days. You will remember that. Ulti karke aao, get done with the exam. Keep on giving 1 GT per week. There is a national, Maro is going to have a free GT for everyone on 16th and till 26th. After 26th, I will discuss it. I will discuss MCQ strategy. After 26th. So ensure you give that Maro GT from 6 to 26, free for all, right? On 26th, I will discuss 10, 15, 20 questions, good questions on how to solve MCQs. Ensure you follow that YouTube session also. Ensure you follow that. This will be on YouTube. Ensure you follow that YouTube session. We'll have a GT discussion also. Okay? All right. So transfer of objects is 7 months, not 6 months. It is 7 months. Remember, it is 7 months. 6 months, you cannot transfer objects. See, how will a baby transfer object at 6 months? He's having ulnar grasp. He'll drop it if he wants to transfer. The minimum is 6 months. The minimum is 7 months, not 6 months, 7 months. See, sometimes questions come like this. When does transfer of object occurs? Let's say the question is this. A, B, C, D, 3 months, 6 months, 9 months, 12 months. And then there is a same question, transfer of objects occurring at 5 months, 6 months, 7 months, 12 months. In this, obviously, the answer is 6 months. In the other question, the answer is obviously 7 months. But the better answer, obviously, if both 6 and 7 months are given, 7 months is a better answer. 7 months is a better answer. I'd covered most of the important things. A little bit, you can obviously go back, read from your own, a little bit from your own side. See, general pediatrics, I've done mostly. Only systemic pediatrics, few topics here and there you have to read yourself. You can do that. Thank you.